No. Now it's coming. Delay is there. Hello. Good evening, everyone. This is Dr. Jambukeswaran, PrepLadder's orthopedic faculty for you. Today we are going to see the LRR INI-CET May 2026. Am I audible and visible clearly, dear friends? Give me a thumbs up sign. Hello, yes. Agastyan, yeah, very good. Agastyan, Shivangi is there. Okay, yes sir, yes sir. Yes, okay. Thank you. Okay, so dear friends, yes, thank you, yes, yeah, I got you, yes. So, dear friends, today in this YouTube, okay, so what I am going to do, the past 5 years question bank topics. We are not going to discuss the whole thing or unnecessarily the past. So, how I framed is, first I have framed my own question. And that question I have marked that as a real question. Okay. Once we answer that question, we will go to the real question that has been asked in the INI-CET. Then we will discuss the topic. This is how I have framed this session. Definitely it will be high yielding and very, very rewarding. Okay. So let us start directly. Okay. Let us start directly. We'll go to the first real question. Okay. The question which I framed. Real question. First line investigation for skeletal tuberculosis. Please answer carefully. Don't jump into conclusion. First line investigation for skeletal tuberculosis. First line investigation for skeletal tuberculosis. Yes. Yes. Danush have answered C. Yes. Bhagyashri. Ashutosh. Okay. Saidia. Dr. Doom. Okay. Yes, Ames. All of you answer that as C. Excellent, man. The right answer is CB-NAT. CB-NAT stands for cartridge-based nuclear amplification analysis test. So CB-NAT. That's the right answer. Because the question asked is first line investigation for Epic Edge. So many love symbols and you are the best. Love you, sir. Okay. I love you. Okay. Epic. I love you. Okay. Right. You see here, the first line investigation for skeletal tuberculosis is CB-NAT. Please focus your fullest attention. Skeletal tuberculosis means extrapulmonary tuberculosis. That is the word. Yes or no? Yes. If pulmonary tuberculosis, first line investigation should be X-ray. Extrapulmonary tuberculosis, X-ray is a very late investigation. It won't show you anything in the initial phase. So WHO has very clearly said that the first line investigation for extrapulmonary tuberculosis is CB-NAT. This is our question and all of you have answered that as excellently. You have answered that as correctly. Superb. Okay. Now we will go to the real question that has been asked in INI-CET. According to WHO, which of the following is the recommended diagnostic test for spinal tuberculosis? This is the question. For they had used the word spinal tuberculosis. That means it's extrapulmonary. And which of the following is the recommended? You should analyze all the 4 choices. Then you should give the answer. Yes. Ratan Deepak. And Alek have asked a question, sir, will this be useful for FMGE? 100%, man. Definitely. FMGE, it's not an exam which is out of universe. It is happening in India, no? So India, all are one and the same. Yes. You see here. Yes, according to WHO, which is, what is the answer? Yes. Yeah. Yes. Gracia have given an answer, right answer. Yes. Gracie Irudayaraj has given the right answer. And yeah, that's why I said, see, not because culture will take time to, okay, Dr. Ankit Create is giving an answer. And you see, again, dear friends, I want to tell you, if according to WHO, which of the following is the recommended diagnostic test for spinal tuberculosis, you see, among the four, this you should not ask me a question, is this question correct, because this is an asked question in INI-CET. Just I have presented it as such, I have not altered. They should have asked, in WHO first line means confidently you can answer this. Otherwise, if they ask a question WHO, the confirmatory test, if they use the question, you have to go for culture sensitivity. Okay, again, this is an ambiguous question which has been asked in INI-CET. Few students have answered this and few have answered this. So now let us see the topic correctly. Investigations for skeletal tuberculosis. Okay, investigation for our orthopedic skeletal tuberculosis. WHO strongly recommends CB-NAT as the first line test for extrapulmonary. If they use the word first line test, yes, Ratan Deepak, you have answered it correctly. Excellent. WHO strongly recommends CB-NAT as the first line test for extrapulmonary tuberculosis, including spinal TB, because it gives results within hours and so that we can start treating the patient. There is no delay in treatment. So this is a valid point. However, due to certain limitations, it cannot replace culture and sensitivity, because culture and sensitivity is 100% specific. It's 100% specific. According to WHO, the recommended and definitive diagnostic, if they use the word from the textbook, definitive diagnostic test, then it is culture and sensitivity. So 2 points we got. 1 point here, another point here. We got 2 points. Okay. You see here, MRI. What is the use of MRI? It is investigation of choice to evaluate type and extent of cord compression. If at all they use the word for part spine, nerve compression, part spine with sciatica, part spine with pain which travels to the thigh and the leg, something like that. If they ask what is the best investigation, then we have to go for MRI. MRI is the investigation of choice to evaluate type and extent of cord compression, investigation of choice for part spine and parts paraplegia. If they use the word part spine, parts paraplegia, yes, and okay, it is our MRI, but it doesn't help to, this is the limitation of, see, MRI is an excellent investigation, man, there is no doubt. Look at one limitation, it doesn't help to visualize bony vertebral destruction. MRI is not suited if you want to assess the body of the spine, destruction of body of the spine, then MRI is not a good investigation. So this is the limitation, this we should have in the mind, that because it's only a week more, okay, last resort revision. So just have this in your mind. Early signs, spinal nerve root and paraspinal soft tissues are better visualized and best investigation modality overall for part spine. Okay, yes. CT scan, most preferred imaging modality for the assessment of destruction of the vertebral body and sequestrum formation. If you want to see, you know there is a sequestrum which is formed in parts paraplegia. The name of the sequestrum is called kissing sequestrum. Okay, you would have read this in osteomyelitis. I am going to teach you again. A question is coming. Kissing sequestrum is the specific sequestrum that is formed in part spine. If you want to visualize that, MRI is useless. CT scan is the best investigation. Last but not the least, X-ray is useful as an initial imaging tool, but it lacks sensitivity and may miss early disease. So this is not the first line for extrapulmonary tuberculosis. We will move on to the next question, a real question. Yes, next question. Okay, yes. FMG, okay. Okay, Ratan Deepak Kaur. Okay, good. Excellent. Actually, I am studying State University, Kingston, preparing for FMG. All the best. All the best, Ratan. Okay, you will do it. The best investigation to detect occult fracture scaphoid. Occult, what is the meaning of occult? Occult means hidden. not seen very easily, hidden fracture scaphoid. That's why it's called spina bifida occulta. Occulta means closed spina bifida, not seen openly, not seen easily. That's the meaning. So what's the answer? Best investigation. Yes, best investigation for, yeah, aspirant Rahul Jania, Bhagyashri, yes, Dr. Bella, Vikash Raj, Dhanush, all of you have answered it correctly. Superb, your aspirant. All of you are answering very well. Ankit creates, excellent man. Best investigation to detect occult fracture scaphoid is MRI. Okay. This is the real question which I have framed from the topic. Now we see the real question of INI-CET. A patient presents after fall on an outstretched hand. The X-ray is normal. Simple, our normal digital routine X-ray is normal, but there is fullness and tenderness of the anatomical snuff box. What is the next best management? Okay, this question have been repeated to my knowledge thrice. In NEET PG, INI-CET like that thrice. Okay, very sensitive question. So what will you do? The question, MRI to evaluate, immediate CT scan, cast mobilization and follow up, bone scan for early. Okay, yes. All of you have marvelous. Okay, Valley Third, Rahul, okay, Parneet Kumar, all of you have answered it correctly. Superb. The next thing, what you should do, a patient, see, clinically we are suspecting scaphoid fracture. When somebody has fullness and tenderness in the anatomical snuff box, it is scaphoid fracture, fall on outstretched hand history is there. It is scaphoid fracture unless or is proved. Even X-ray doesn't show you anything properly. Better treat that as a scaphoid fracture, treat it with a scaphoid cast and follow up after 2 weeks, repeat the X-ray. If X-ray shows signs of fracture healing after 2 weeks, continue the cast for 10 weeks. Okay, continue the cast for 10 weeks. Even after 2 weeks, X-ray not showing anything, no signs of healing fracture, remove the cast and let him free. Because as far as scaphoid fracture is concerned, over treatment is justified than under treating a patient. Because we know the dreaded complication of scaphoid fracture. Okay, I will tell you, because the dreaded complication, the radial artery enters through the distal pole, common site of fracture is waist, so proximal pole will go for avascular necrosis, and that's called Periosteal disease. Once you know the age group of scaphoid fracture, the scaphoid fracture commonly happens in young adults. Fall on outstretched hand, elderly will go for Colles fracture. Fall on outstretched hand, young adults will go for scaphoid fracture. Once in a young patient, if the proximal pole goes for avascular necrosis, lifelong he will have wrist pain. That is the notorious dangerous complication of the scaphoid fracture. Okay, so over treatment is justified than under treating a scaphoid. Now coming to scaphoid fracture in a patient who presents after fall on outstretched hand, the primary clinical diagnosis is scaphoid fracture. These fractures can be radiographically occult in early phases due to its limited blood supply. Okay, and the distal pole, the proximal pole can go for avian. Hence, the next best step is management in cast immobilization and repeat the X-ray after 14 days. You know this cast is called Bowler gauntlet cast. B-O-H-L-E-R Bowler G-A-U-N-T-L-E-T. Bowler gauntlet cast. You know name of the scaphoid cast is Bowler gauntlet cast. And it is the below elbow POP cast in glass holding position. Glass holding position. Okay, like this. The cast will be like this, like a glass holding position. Okay, so this is the treatment of choice. Now, MRI. What is the indication of MRI? You see, sir, is this enough for INI-CET revision? Definitely, man. This is last resort. See, I have just collected all the high yielding topics. Guaranteed some questions will come, get repeated. Definitely. Okay, in the last minute, we can't read too much. Okay, why not, sir? Kindly explain. I don't know, but I started liking to learn ortho. Okay, yes, if there is any careless, right? Okay, yes. Okay, humpback deformity, right? You should give treatment before because it's often missed. Yes, yes. Okay. Why not, sir? Kindly explain. What is that? Ankita, what is your doubt, man? What is your doubt? Please explain. What is your doubt? Okay. Why not? The answer is A. You are asking why not? The best in. Okay, here. MRI to evaluate soft tissue. This is your doubt, no, Ankita? Yes, Ankita, you have. Yes, Ankita has this doubt. Why can't you answer MRI to evaluate soft tissue as the what will you do next after this? Why you are going for treatment? This is the question. No, my explanation is coming. My explanation is coming. You see here, this we have completed. You see, MRI to evaluate soft tissue and ligaments, it's okay. It will detect. MRI has high sensitivity for occult fractures, but not routinely the next step unless urgent diagnosis is needed. He is an athlete who is playing on the ground, urgent. Otherwise, follow-up is not possible. Okay, because everything is weighed according to not. You can't directly from everything from the textbook, especially Western textbooks. Our country and our practice, we have a value. It's a very, very practical question in INI-CET and NEET PG, thrice repeated. Same question, almost same choices. Because in practice, this is the thing we encounter daily. Just like that, I can't order an MRI which costs 6,000 rupees. Okay, I can't. Because if it is not clearly coming to the point, if it's not clearly seen, X-ray, you are not able to visualize even in a digital X-ray, guaranteed that is not a displaced fracture. Guaranteed that's not a displaced fracture. If at all, it is only an occult fracture. Occult fracture treatment of choice is below elbow POP cast in glass folding position for 8 to 10 weeks. That's the treatment. Okay, that is why in our practice, I will treat that as a scaphoid fracture. I will explain to the patient very well. This X-ray is not very clear, but clinically I am suspecting this. This is the treatment for this. Go ahead with the treatment. Come to me after 2 weeks. I will do a repeat X-ray. If repeat X-ray shows a healing fracture line, we will continue the cast for 8 to 10 weeks. If after 2 weeks, if doesn't show any healing fracture, we can remove that. This what? Okay, so that's why MRI, it's not suddenly you won't do MRI as the next step. That is why they are framing this question. This is a very slippery area. Many students may take MRI, and our setup, our exam is not exam of selection. It is exam of elimination. How to eliminate you. That's why, since it's slippery, they will feel, this means first time a question is repeated for the second time, it means first exam, many students have answered that wrongly. Okay, we should not do that mistake. That's why I am taking so much time and then explaining this to you. Okay, Ankita, I think by this time you would have been satisfied with my explanation. Then you see CT scan, what is the role? CT scan is good for detecting displacement. A displaced fracture, it will show, otherwise it won't show. Bone scan for early fracture detection. Bone scan can be used in diagnosis when remains unclear, as they are more sensitive and detecting fractures, but similar to MRI, it's not routinely used as next step unless the diagnosis is very urgent or follow-up is not possible. Okay, bone scan, there is no doubt MRI will show you very early, bone scan will show you. The problem is very expensive. Okay, yes. Now coming to the third real question. Okay, yes. Okay, now coming to the third real question. Yes. Yes, most common organism causing implant-induced osteomyelitis is Staph aureus, Staph albus, Streptococcus klebsiella. Implant-induced, most common organism, implant-induced. Again, this is a very, very slippery area, dear guys and girls. This is a very slippery area. Most common organism causing osteomyelitis is Staph aureus. There is no doubt. Implant induced, you are putting a plate or a screw inside, and what is the most common cause? Most common cause, yes, shall I give? So this is, yes, Shaheen has answered it correctly. Mohit has answered it correctly. Okay, Mohit has answered it correctly. The most common organism, I will go to the answer. The most common organism causing implant-induced osteomyelitis is Staphylococcus epidermis. Staphylococcus epidermis is otherwise called Staphylococcus albus. Otherwise called Staphylococcus albus. This is a real question, a slippery question I have framed. Now coming to the real question of INI-CET, a 10-year-old boy presents with pain and swelling around his right knee. Pain and swelling around his right knee. There is no history of trauma. There is no history of trauma. On examination, there is localized tenderness over the distal femur. X-ray reveals sclerotic changes in the metaphyseal region. You see, sclerotic changes, metaphyseal region, which features such as sequestrum and involucrum. Laboratory investigation shows mild leukocytosis, elevated ESR. Which of the following is least expected? Okay, you see, classically this is a case of chronic osteomyelitis. This is a case of chronic osteomyelitis. The question asked is least expected organism. Least expected organism. So this is the question. Yes, Syed have answered, Bella have answered, Pooja have answered, Aspirant have answered, Pepsi, okay, Dr. Pepsi have answered, Mohit, superb, Sangeeta, marvelous guys. That means it shows one thing very clearly, you have revised everything and you are ready for the exam to crack, okay? Let us do it, right? The least common organism is Klebsiella pneumoniae, because you see here is a 10-year-old boy child. Only in the history 10-year-old child is there, pain swelling is there, okay, and it's very clear it's a case of chronic osteomyelitis. That's all, no extra point. You come to the causative organisms of chronic osteomyelitis, the presentation and imaging, everything is consistent with chronic osteomyelitis, and the common spread is hematogenous. That's okay. Klebsiella pneumoniae is rarely a cause of chronic osteomyelitis in a healthy pediatric patient. Then where this Klebsiella osteomyelitis is common, in hospitalized, is more common in hospitalized immunocompromised adults. This is the point. Next time how they will frame a question, they will give the same choices and they will slightly change the question. A common organism that is implicated in causation of osteomyelitis in a long-term hospitalized immunocompromised adult. If they ask a question, then you should vote for Klebsiella pneumonia. Klebsiella pneumonia, okay? And one extra question, Klebsiella, shall I ask you, what is the many organisms can cause? I will ask one general medicine question. I am going to ask you a general medicine MCQ. Many organisms will cause pneumonia. What is the speciality of Klebsiella pneumonia? Yes. Come on, man. Answer. Suddenly this MCQ is coming to my mind. It's not our subject, but it's okay. Come. Klebsiella. Yes. Mohit has answered recurrent jelly sputum. Marvelous. In all other pneumonia, the sputum will be rusty. A recurrent jelly sputum, Klebsiella pneumonia. Good, Mohit. Excellent, Mohit. Then, yeah, many of you have answered. Yes, Priyanka has answered bulging fissure sign. Okay, bulging fissure. Yes, because Klebsiella, it causes pneumotocele. It causes pneumotocele and it causes bulging fissure. It causes bulging of the fissure. In X-ray, no, pneumonia changes are there. With the bulging of fissure, rule out Klebsiella. Clinically, patient is bringing out a recurrent jelly sputum, rule out Klebsiella. Okay, Klebsiella is a nosocomial infection. So those who have got hospitalized in a bed for a very long time and he is an immunocompromised, for example, an uncontrolled diabetes mellitus, or he is a known case of some malignancy. This pneumonia is very common. Okay, superb and marvelous, man. And it's common in alcoholics, and Deepankita Das, okay, has given a superb thing. The test is called string test. Good. That means you are in the groove. Okay, all of you are set ready for the exam. Most common organism, there is no doubt, Staphylococcus aureus. Okay, both in acute, subacute, chronic, wherever it is. In foreign body implants, Staphylococcus epidermis is the most common. This from the textbook happily, and we have to remember this slippery point. Streptococcus pyogenes can cause, okay, E. coli Mycobacterium tuberculosis also causes chronic osteomyelitis. Okay, yes. Now we'll go to the next real question. Okay, framed MCQ. All are causes for sacral insufficiency fracture except. See, this topic again, a very favorite topic of this INI-CET. I don't know, certain topics they will get fixed. They will ask again and again the same question. This sacral insufficiency fracture, you should know. Okay, you should know. One question will come either NEET or INI, that we can't guarantee, but it's a very favorite area. All are causes for sacral insufficiency fracture except. Yes, come on. Yes, many have answered, but I have framed this question so little slippery. Okay, Bhuvan have answered it correctly. Bhuvan Sabitha, yes, have answered correctly. Parneetkar has answered it correctly. Dr. Bella have answered it correctly. Okay, Painkiller has answered it correctly. Subhashini MBBS have answered it correctly. Marvelous, man. All are causes for sacral insufficiency fracture. Steroids, very important cause. Paget's disease, one of the important cause for metabolic bone disease causing sacral insufficiency. Rheumatoid arthritis, again it is a cause because treatment for that is steroids. And osteoarthritis is no way connected with sacral insufficiency because osteoarthritis is a degenerative joint disease. Sacral insufficiency instead of osteoarthritis, here it should come osteoporosis, which is the most common cause. Okay, see, sacral insufficiency fracture is a type of stress fracture which happens in the pelvis, in the sacrum. Okay, sacral insufficiency. Now quickly we will see the real question they had asked in the INI-CET. A patient presents with low back pain. Bone scan reveals the characteristic Honda H sign. What is the most likely diagnosis? You are able to see here. Okay, change exactly looks like the Honda car symbol. Okay, this is called Honda H sign. Okay, so now the answer, very good. All of you have answered. This was the asked question. It is bilateral sacral insufficiency fracture. Bilateral sacral insufficiency fracture. Okay, Honda H sign is low backache, Honda H sign. Now quickly we are going to see. Yes. Yes, INI-CET May. Very good. INI-CET May. It was an asked question. No? Yes. You see, now let us quickly see the salient important points. Sacral insufficiency fracture is a subtype of stress fractures which are the result of normal stress on abnormal bone. Normal stress on abnormal bone. What abnormal bone? Osteoporotic bone. Normal stress, patient is sitting suddenly and he is an osteoporotic patient, can develop that. Most frequently seen in setting of osteoporosis, they fall under the broader group of pelvic insufficiency fractures. Okay, now what are the risk factors? This is the question. This time if they reframe the question, all are causes for sacral insufficiency except osteoporosis, most common cause. Rheumatoid arthritis is the important cause that is mentioned. Paget's disease, osteomalacia, which is vitamin D deficiency. There it is called that milkman's fracture. It's not syndrome, milkman's fracture. Diabetes mellitus is a cause that is mentioned in the book. History of radiotherapy, radiation, long-term bisphosphonates like your alendronate, zoledronic acid, long-term bisphosphonates and long-term steroids. These are the risk factors. These are the risk factors. Now, clinical presentation, they are usually seen in elderly females who presents with low back pain without any history of trauma. They won't give any significant history of trauma. Okay, they are most frequently seen in setting of osteoporosis, although anything which weakens the bone is a cause. All the causes I had mentioned. When you take an X-ray, X-ray may be normal, okay, or a sclerotic line may be noted in the involved region. CT scan may show a fracture line along with sclerosis that is parallel to the sacroiliac joint. MRI can depict bone marrow edema as early as 18 days after development of sacral insufficiency fracture. Because X-ray is not reliable, it won't show, practically speaking, it won't show anything. CT scan may show, MRI may show edema, bone marrow edema as far as the 18th day. Now coming to this point, nuclear medicine. Honda head sign we are seeing. Where Honda head sign is seen? It is seen only in nuclear medicine. Uptake of technetium-99 MDP is a sensitive but not a specific, a typical H or Honda sign may be noted. If you are seeing a Honda sign like this, definitely it's seen only in 20 to 40% of the cases again. But when you see a Honda H sign, definitely that is a case of sacral insufficiency fracture. It's a case of sacral insufficiency fracture. How we are going to manage? Most of the cases can be managed conservatively. Conservatively means just to give bed rest, some painkillers, and you see whether the patient is having any osteomalacia, they are replaced with vitamin D. Just conservative. Mostly it will settle. Very severe cases, severe collapse of the sacrum has happened, total anatomy is altered, then you have to reconstruct the sacrum, and that is called sacroplasty. That is called sacroplasty. Okay, so most of the cases can be managed conservatively. What is that? Bed rest, non-steroidal anti-inflammatory drugs with vitamin D and calcium. That's all. Okay, so this is whatever book you read, these are the salient points about sacral insufficiency fractures. We'll move on to the next real question, next topic. All are causes for periosteal elevation except. This is, I framed this question, very simple, straightforward question. All are causes for periosteal elevation except. Yes. Yeah. Rashmi, aspirant, Bhuvanesh. Marvelous, man, marvelous. Just like that you banged all of you. Oh my God. How many answers are coming? How many correct answers are coming? Very good, very good. So all are causes for periosteal elevation except osteoporosis. Because in osteoporosis, there should not be any periosteal reaction. Only thinning of the periosteum. What will happen in osteoporosis? There is only thinning of periosteum. In periosteal elevation or periosteal reaction, there will be thickening of periosteum. In osteoporosis, an ulta condition, thinning of periosteum. That is why it's called pencil. The cortex is called pencil thin cortex. The cortex is called, the cortical thickening will go down. Periosteum, there will be thinning. So it is called pencil thin cortex in osteoporosis. Okay. Yes. Now the real question of INI-CET. A 17-year-old boy presents with a progressive increasing swelling over the tibia, along with fever. Radiological examination reveals a Codman's triangle. The answer they had given. And sunburst appearance. What's the most likely diagnosis? There is no second thought. Yes, marvelous. All right answers are coming. Excellent. Okay, there is no second thought. It should be a case of osteogenic sarcoma. Okay, osteogenic sarcoma. The X-ray findings of 3 major bone tumors, primary tumors of bone. Okay, I had not included multiple myeloma in this. 3 major osteogenic sarcoma, giant cell tumor, Ewing sarcoma. 3 major things. These are the radiological features. Please focus your full attention. I make it very simple. I will finish in 1 minute. You see here, when you closely observe, the periosteum is elevated like this. Periosteum is elevated like this in this area. Okay. Here also you can see periosteum is elevated. This. Okay. You zoom. This is called Codman's triangle. Okay. Codman's triangle. Codman's triangle. This is called Codman's triangle. Elevation of the periosteum. The point I want to stress is whenever there is elevation of periosteum, the most common cause for elevation of periosteum is osteomyelitis. This is the most common cause. Then a very important cause which is outdated disease nowadays. There is no such disease now because of penicillin. Syphilis is gone, but once upon a time this was a big cause. Congenital syphilis is a very important cause for periosteal elevation. Then vitamin C deficiency, periosteal elevation. Vitamin C deficiency, periosteal elevation. Instead of osteoporosis, it should be osteogenic sarcoma. Osteogenic sarcoma, this is a very important cause. Then last but not the least, periosteal elevation. One should not forget myositis ossificans. Myositis ossificans. These are the ortho conditions that causes periosteal elevation. Okay, yeah, and very good. Gaurav Singh, very good. That's called, that when it's due to syphilis, that is called saber shin. So they had answered, it's called saber shin, right? Excellent. Okay, yes. So and yeah, that is called, and Debunk Das has answered interstitial keratitis. He's studying congenital syphilis. He's telling that triad of congenital syphilis, a peg tooth, interstitial keratitis. Okay, so he is telling that interstitial keratitis is a feature of congenital. That means you have read pediatrics very well. Excellent, superb. So the causes for periosteal elevation is, these are the causes: osteomyelitis, syphilis, scurvy, osteogenic sarcoma, myositis ossificans. In all these things, it is called periosteal elevation. When periosteal elevation is due to osteogenic sarcoma, this alone is called Codman's tumor. This alone, it is called Codman's. The point I want to stress you, there are 5 causes for periosteal elevation. When it is due to osteogenic sarcoma only, then only it is called Codman's triangle. In all other situation, it is called periosteal reaction. Like that, this name is reserved for periosteal elevation due to osteogenic sarcoma, Codman's triangle. Like your evening rise of temperature happens in all fever, but the word evening rise of temperature is reserved for tuberculosis. Like that. Okay. Now you see this point, that's called Codman's triangle. That's called Codman's triangle. The second change, one should not forget, all these can be repeated in image based. You see here, one main tumor is there, and I am seeing layers like this. This is called sunburst appearance. Sunburst appearance. Sunburst appearance, what is the mechanism? Very good, very good. Okay, Deepan Das have answered. Sunburst appearance. Why the sunburst is happening? You should know. See, X-ray can detect only bone or calcium related substance. Definitely blood vessel X-ray cannot show. Okay, what is the theory behind the sunburst appearance? You see, sarcoma is a vascular tumor. It's a vascular tumor. From the main tumor, lesions of blood vessels will go like that. Lesions of blood vessels will go like that. For example, you take this as the main tumor. Lesions of blood vessels will go like that. Blood vessels X-ray can't detect. What is happening in osteogenic sarcoma? Microcalcifications are happening along the vessel wall. Microcalcifications are happening along the vessel wall. Microcalcifications happening along the vessel wall. That microcalcification, the lesion of blood vessels around that, which is surrounded by this microcalcification, that is seen as a sunburst or sunray appearance. This is the theory behind sunray appearance in osteogenic sarcoma. Now this X-ray, when you see, I will rub all these things. Here, this periosteal elevation here is in the form of sunburst appearance. The periosteal elevation here, it is in the form of Codman's triangle. When you see this tumor, absolutely no periosteal reaction. Absolutely no periosteal reaction. Instead of that, the periosteum appears very thin. Inside, I am seeing lot of trabeculations. This is called soap bubble. This is called soap bubble. Okay, very characteristic of GCT, giant cell tumor. GCT. This is the classical giant cell tumor. Osteogenic sarcoma is most common around knee joint. Giant cell tumor again most common around knee joint. Then the third, you see here, you zoom this, your app, and see your cell phone or your laptop, your iPad. You see here, you can see multiple layers of stripped periosteum. I will rub it. You see now. Multiple layers. Periosteal reaction. This is also a periosteal reaction. But periosteal reaction here, how it exhibits multiple layers of stripped periosteum. And this is called onion peel. This is called onion peel. Okay, the diagnosis is Ewing's sarcoma. These 3 questions they have asked several times. In Ewing's sarcoma, exactly like this, when you see here, I am able to see very, you should you raise your background lighting and you zoom and see, here absolutely no periosteal reaction, soft tissues, you can't see anything. In this situation, some sort of periosteal reaction is seen. Closely you watch this much periosteal reaction is seen. Within that, exactly it look, but it's here it looks very osteoporotic, and you are seeing microtuberculation exactly like a soap bubble. Here it seems as if something has bitten the bone, and this is called moth-eaten appearance. Exactly, moth-eaten appearance. Okay, again the diagnosis is Ewing's sarcoma. See, dear friends, I want you to stress a point. Only unasked X-ray finding in bone tumor is this. So, if at all they want to ask a new question, this should be the question. Moth-eaten appearance of the bone. If they ask a question, moth-eaten appearance of the bone, only two causes are there in ortho. Number one, Ewing's sarcoma. Number two, don't forget YAS. YAWS, YAS. YAS, where we read in micro, non-venereal syphilis. You remember that non-venereal syphilis? Yas, Pinta, Bejel, Parangi, Payan. Five forms. This non-venereal syphilis can manifest in 5 forms. Okay, Treponema pallidum syphilis is venereal. Non-venereal syphilis, Yas. Yas is outdated now. They are eradicated. Yas, Pinta, Bejel, Parangi, Payan. 5 things that Yas in bone is producing moth-eaten appearance. Okay, then Ewing's sarcoma, moth-eaten appearance. Okay, marvelous. Okay, so okay, Shubhi have answered that as yes, marvelous man, excellent. Okay, we will move on to the next question. Best real question, a framed question. Best treatment for stable intertrochanteric fracture. Again, this intertrochanteric fracture management, very favorite area of INI-CET. Very favorite area. Okay, yes, moth-eaten, multiple. Dr. Crick is asking a question. Moth-eaten appearance, can it happen in multiple myeloma also? See, in multiple myeloma, it is called punched out lesions, man. In multiple myeloma, it's called punched out lesion. The word moth-eaten is not mentioned in the textbook. Okay, it's punched out lesions. Okay, of the bone, multiple myeloma. Okay, excellent. Very good. All of you have answered. Superb. Okay. Yeah, so many right answers. Superb. Excellent. Okay, best treatment for stable IT is dynamic hip screw. Marvelous. Dynamic hip screw. Now we will go to the real question of INI-CET. A 78-year-old female sustained an intertrochanteric fracture. Which of the following is the best management? They had given 4 choices. Proximal femoral nailing, internal fixation with screw, prosthetic replacement, boot and traction. See, boot and traction is conservative. 78-year-old, when you give boot and traction, when you don't immobilize her for 48 days, she will die of bed sores. Ruled out. Prosthetic replacement, this is for neck of femur fracture. Prosthetic replacement means head and neck is replaced. That's called hemiarthroplasty. This is for neck of femur fracture. So that is wrong. Internal fixation with screw is very vague. Okay, internal fixation with screw, that is called 3-point screw fixation. This again is for fracture neck of femur, not for intertrochanteric fracture. That is wrong. Proximal femoral nail is the right answer. Okay, yes, Dr. Pepsi and many of you have answered. So proximal, in the 4 choices, these 3 definitely not the answer. This is not the answer because it's conservative, so it's not the best. These 2 are for neck of femur fracture, not for intertrochanteric fracture. Okay, now let us see the scientific management of intertrochanteric fracture. I will finish in 1 minute. Focus your fullest attention. It is very simple, highly expected area, man. This is highly expected area. Focus your fullest attention. Okay, I'll make it so simple for you. You see here, everyone knows intertrochanteric fracture is between greater trochanter and lesser trochanter. In greater trochanter, 2 great muscles are attached, medius and minimus. In lesser trochanter, iliopsoas. So whenever a fracture happens between greater trochanter and lesser trochanter, the muscles are pulling, so invariably the fracture will be displaced. The fracture will be displaced. Now for that they had given a gray classification. It is there in our main video. It is there in our rapid revision. You see, Boyd and Griffin. Only when you know what is Boyd and Griffin, then only you can understand the management of IT. Because more than 2 or 3 correct answers, it may come in the choice. Okay, there are 3 types of treatment that are possible for IT. Please focus your fullest attention. There are 3 methods of treatment that are available for intertrochanteric fracture. They will give all the 3 and they will give one type and they will ask. Okay, very simple. Type 1 fracture, okay, boot and traction, okay, right. You see, type 1 fracture along the intertrochanteric line of GT. You see, GT, LT, one fracture line. It is totally undisturbed and it is not displaced. Only this type 1 is called stable fracture. This alone is called stable fracture. Okay, when they give a diagram like this or when they explain type 1, this alone is called a stable fracture. Type 2, same thing from GT to LT, but so many communications are there. So this is an unstable type. This is an unstable type. The third type, fracture begins at or below LT extending into the subtrochanteric area. This again, it is an unstable type. The last one, the fracture begins at LT and extends into the see, all the fractures are happening like this. This fracture is happening like this. So this is called, the last type is called reverse oblique. Reverse oblique type. Okay, this is called reverse oblique type. This again, highly unstable. Highly unstable. Highly unstable. Okay, you just please revise type 1, fracture between greater trochanter and lesser trochanter, undisplaced. This is type 1, this is stable IT. Type 2, comminuted fracture between GT and LT, so this is unstable IT. Third one, fracture begins at LT and goes into the subtrochanteric area, this is unstable IT. Last type is called reverse oblique, very highly unstable type. Okay, so dynamic hip screw is the best treatment only for this. Dynamic hip screw is the best treatment only for this. And if at all you want to try boot, you can try only for type 1. For all these other types, the best treatment is proximal femoral nailing. Okay, PFN, proximal femoral nailing. Okay, proximal femoral nailing. So for this type, best management is PFN. For this type, best is PFN. For this type, again, only PFN. Okay, the DHS is the best treatment for type 1. Okay, type 1. Right, now you see, this is called traction and boot is not the correct word. It is correctly called derotation boot. This is called derotation boot. Okay, olden days, before surgical era, put the patient, when somebody is suffering from intertrochanteric fracture, they are made to lie down in a bed and the foot is given. Here underneath, I will keep a scale and put a POP. And POP only up to level of just below the calf muscle. So when a scale is there, I cannot do internal rotation or external rotation because underneath the scale is there, the scale is touching the bed. So I can't do internal rotation, external rotation. So the intertrochanteric area is undisturbed. 45 days patient has to lie in this position. And where it is happening, it's happening in old individuals. When you don't mobilize them for 45 days, what will happen? Hypostatic pneumonia, bed sores. Okay, so this was once upon a time, this was a treatment. So ideal thing for type 1, the best treatment, this is called dynamic hip screw. This is called dynamic hip screw. This is the treatment of choice for type 1. Otherwise, stable IT. If they use a word, stable IT. Okay, stable IT, dynamic hip screw. See, one main screw is there in neck and the head. Another plate they had kept in the femur, shaft of femur. They had fixed it. So what happens? This screw which is inside, it is that main screw is sliding. It is sliding. So this dynamic hip screw is otherwise called sliding hip screw. When the patient starts walking, micro movement happens in the fracture site. Micro movement enhances good bone healing. Since the screw is not very static, little dynamic, that is called dynamic hip screw. For all the type 2, type 3, type 4, okay, for all other intertrochanteric fracture, this is the best thing. This is called proximal femoral nail. This is called proximal femoral nail. Okay, I think I am with you. I think you understood the concept, so that whichever way they ask the treatment, we can manage. Please show me a thumbs up sign so that we can go to the next question, please. Am I clear, dear friends? Okay, sir. Yes, sir. Maza are okay. Superb, superb. Thank you, thank you. Thank you, Bala. Thank you, Bella Pepsi. Yes. We'll move on to the next framed question, real question. Okay. Patient had an RTA. Which area fracture is more prone to cause foot drop? This area, again, repeatedly asked area in INI-CET. Lateral tibial condyle, medial tibial condyle, avulsion of the tibial spine, mid shaft of the tibia. Every superb. Okay, excellent. Okay. Yes, marvelous, man. Superb response. All of you have answered it correctly. All of you have answered it correctly. The right answer, patient had an RTA which the fracture is more prone for foot drop. Lateral tibial condyle fractures. Okay, proximal tibial fractures are classified according to Schatzker-Tiles classification. One type is lateral tibial condyle because lateral tibial condyle is close to the fibula, head and neck of the fibula. So common peroneal nerve wounds around the neck of the fibula. So when lateral tibial condyle is fractured, that will go for injury to the common peroneal nerve and it can cause foot drop. It can cause foot drop. Now the real question that has been asked in, yes, that has been asked in, okay, yeah, Schatzker-Tile, good, Supriya have answered that, good. A patient presents in OPD after a road traffic accident complaining of being unable to dorsiflex and evert the ankle. Dorsiflex and evert the ankle. Okay. X-ray was ordered by the attending physician. X-ray was ordered by the attending physician. In addition to observed injury on the X-ray, which gait anomaly is likely to be present? Okay. What is the gait? Yes. Very good. Okay. Again, all of you have answered it correctly. Very good. Right? Okay, so all of you have answered it correctly. Marvelous. And that is called, this is called stepping gait. Originally, this is called high stepping gait. This is called high stepping gait. High stepping gait. Okay, marvelous. Now you see, X-ray shows fracture neck of fibula. Common peroneal nerve is common at the veins around the neck of the fibula, which leads to foot drop, inability to dorsiflex. Stepping gait. Stepping means the word they are given is stepping. It's called high stepping gait. Commonly seen because high stepping gait, what is that? The patient is not able to dorsiflex the foot. The patient is not able to evert the foot. Okay, when they walk, it's called high stepping gait. Yes. Foot racing splint. Yeah, Dr. Ankita creates is asking a political question. TVK or DMK? No politics in classroom. Okay. Only MCQ. You should ask me a question, INI-CET or NEET. That's all. Right. Common peroneal nerve injury. What are the causes? Neck of fibula fracture. Hip dislocation. What are the causes for foot drop? Common peroneal nerve injury. Knee dislocation. Proximal tibia fracture. Tight casting. Tight casting. Okay. Yes. Tight casting. Right. So, yes. Okay. The question I asked, Mujbi ma'am is answering only INI-CET. Okay, yes, very good. Right. Okay, right. You see here the clinical evaluation. Okay, clinical evaluation, patient will have a foot drop, patient will have high stepping gait, unable to evert the ankle, decreased sensation on dorsum of the foot and outer part of the leg. Okay, you see here Here the patient is able to dorsiflex. This is normal. In this limb, he is not able to dorsiflex. That is foot drop. This side is the foot drop side. Okay. You see, treatment. This is very important. If no recovery even after 12 months of nerve repair, if there is no recovery even after 12 months of nerve repair, tendon transfer is the only option. The best tendon that is selected is called tibialis posterior tendon. Asked question. Very important. NEET PG. Okay. You can expect this question in INI-CET. Tibialis posterior. Tibialis posterior tendon is transferred in two methods. One method, you are making a hole in the tibia. That is, you are making a tunnel, a hole in the tibia. Through the tunnel, you are taking the tendon. That is called through interosseous route. That's called Bar's technique. Another thing, you are not putting any hole or tunnel in the tibia. You are just wounding. You are taking the tendon around the tibia. It's called circumtibial route, and that is called Ober's method. And practically speaking, best outcome they say it is with Bar's technique. When you take around the tibia, most of the power is lost. This is a very practical thing. Just you remember, if they are given two things when they are asking which is better, go for Bar. Okay. Double tendon transfer, instead here tibialis posterior flexor digitorum longest tendon FH, flexor FDL, flexor digitorum longest tendon. Two tendons are used. The time honored is tibialis posterior tendon technique, and that is called Bar's technique. Don't forget the word BARR, Bar. Right. Few important gaits I will ask you. Okay. Yes. Okay. Yes. Yes. Ober's technique, iliopsoas contracture. Very good. Can't use popliteus tendon. Okay. Right. PrepLadder base. Thank you. Thank you. Yes. Okay. You see scissors gait. Scissors gait. Don't forget cerebral palsy. These are all just revision. Last resort revision. No, high stepping gait, foot drop. Ataxic gait. Otherwise called drunken gait. Cerebellar ataxia, circumduction gait, hemiparesis, stroke, hemiparesis, duck waddling gait, bilateral, this is hip abductor palsy is the mechanism, it is bilateral DDH, developmental dysplasia hip, bilateral DDH, the best is, it's called duck waddling gait, okay, duck waddling gait, then stamping gait, tabes dorsalis, okay. And where did you read your festination gait, short shuffling gait, festination gait, reeling gait, festinant gait? All these names where you read in which condition? Hello? Very good. Yeah, Supriya, Bella. Okay. Then, yes, all of you. Very good, man. Super, super. Excellent. Parkinsonism. Okay. Festinant gait, short shuffling gait, reeling gait, okay. So all these things, okay. Festination gait, that is called, all this happens in one condition, Parkinsonism. Okay, good, marvelous. We will go to the next area. Very importantly, repeatedly they are asked in this area again and again. Okay, they will ask this type or that one. Okay. Hill-Sachs lesion is superomedial, infromedial, posterolateral, anteromedial. Yes. Dr. Ankita, mask-like face in Parkinsonism. You are true, mask-like face. Tremors, rigidity, mask-like face. And hypokinesia. These are the tetrads of Parkinsonism. Good. Right? Yes. Marvelous. Superb. Whichever way you ask, no, our PrepLadder guys, you see how you are answering. Posterolateral. That is superb, man. Right? Hill-Sachs lesion. This is the real question. Real question what they are asked. A patient presents with tear in antero-inferior aspect of the glenoid capsule and the labrum. What is the likely diagnosis for this type of lesion? Answer is Bankhart's. Answer is yes, Bankhart's. Okay. Answer is Bankhart's. Superb. This is the real INI-CET question. Good. Everyone, all of you have answered it. Okay. Now, focus your fullest attention. Again, last resort revision. What are the three lesions that cause recurrent dislocation of shoulder? Number one, Bankhart's. Bankhart's happens antero-inferior aspect of the glenoid labrum. Okay. And this is a soft tissue lesion. Glenoid labrum, soft tissue. So this can be diagnosed only by MRI, not by X-ray, Bankhart's. And it is present in 85% of the lesions. This is the most common lesion, and this is otherwise called essential lesion. Very commonly it is happening. Okay, among the three, this is the most common. And it can be diagnosed only by MRI, Bankhart's. Bankhart's antero-inferior, the mnemonic which I used to teach in our main recording, BAI, by. It's a mnemonic. Bankhart's antero-inferior, by. That's a mnemonic. Okay, Hill-Sachs lesion is a bony lesion. It is a bony lesion. So this can be diagnosed in X-ray. This can be diagnosed in X-ray. Where is the lesion? A depression like, a depressed fracture like a dimple like lesion in the posterolateral aspect of head of the humerus. It's seen only in 25%. When the defect is larger, chances of recurrence is great. Chances of recurrence is more when the defect is larger. This Hill-Sachs lesion is otherwise called Hatchet deformity. Apley's textbook of orthopedics uses the word Hatchet deformity. This is another name for Hill-Sachs lesion. Okay, and since the mnemonic which I use in our main video is HPL. This is a computer company, no? Hewlett-Packard Limited. Like that, Hill-Sachs posterolateral, Bankhart's antero-inferior. So by HPL, these two mnemonics, don't forget, whichever way they ask, we can answer. The third thing that is happening is humeral avulsion of glenohumeral ligament. We know that shoulder stability depends upon glenohumeral ligament. There are 4 important glenohumeral ligaments actually, but most anatomy textbooks uses only 3. But actually speaking, there are 4. In that, inferior glenohumeral ligament is the main support that can go for avulsion. That's called humeral avulsion of glenohumeral ligament. It will go for recurrent dislocation. In some patients, there will be combination of, this is Bankhart's lesion, this is Hill-Sachs lesion, this is humeral avulsion of glenohumeral. All the 3 in one patient. This is called unhappy triad. This is called unhappy triad. Okay. When more than one lesions are seen in the same shoulder at the same time, chances of recurrent dislocation is 100%. That is why it's called unhappy triad. Okay. Hatchet faces. Right. Terrible triad of shoulder, Dr. Bellam. Good. Now we go to the next question, real question. Length of the lateral limb of isosceles triangle in elbow examination is decreased in. This is, I framed this question. Very good. Please answer. Length of the lateral limb of an isosceles. See, when you flex the elbow, I am getting tip of the olecranon, medial epicondyle, lateral epicondyle. I am getting a triangle, and the triangle is called isosceles triangle. This triangle is an equilateral triangle, otherwise called an isosceles triangle. In the isosceles triangle, when length of the lateral limb is decreased, what is the cause? Yes, Supriya K. Supriya K have answered it correctly. Painkiller have answered it correctly. Mohit have answered it. Pooja. Superb man. Shaheen Walia. Hey, great. Oh, our Som Shubra Das. Hey, Das, you have come. How are you, man? Das. Okay, last time, okay, when we were discussing something excellent. So, all of you, Dr. Bella, all of you have answered it correctly. There is no doubt this time, all of us we are going to get. There is no doubt. You are in full form. Okay, yes, the answer is posterolateral elbow dislocation. The length is decreased. You see, this is the real question that has asked in INI-CET. Which of the following fracture does the 3 bony point relationship is maintained? The answer is, this is a real question of INI-CET. Tamil Maran, explain, sir. I am going to explain. Yes, marvelous. All of you have given the right answer. The triangle is maintained only in supracondylar fracture. Now, Tamil Maran, you ask for explanation. Please focus your fullest attention. You see here, the landmarks of 3 bony point relationships are in an elbow, and you should know one thing. When you flex an elbow, then only you should assess. In an extended elbow, you cannot assess. In a flexed elbow, you mark tip of the olecranon, you mark the medial epicondyle, you mark the lateral epicondyle. In a flexed elbow, when you mark, okay, medial epicondyle, lateral epicondyle, tip of olecranon, this gives an triangle. This is called an isosceles triangle. The length of all the three limbs are equal. Isosceles triangle. This is called base. This is medial leg. This is lateral leg. This is medial leg. This is lateral leg. So normally a triangle, when it should be like this. Okay. When you extend the elbow, all these will come in one line. All this will come in one line. So the triangle you can see only in a flexed elbow. If you cannot flex the elbow, you cannot comment on the triangle. Okay. These three bony relationship is maintained in supracondylar fracture. For example, this is the three bony points. This, see, Tamil Maran I am explaining. Please listen. See, this is medial epicondyle, lateral epicondyle, tip of olecranon, a triangle. Supracondylar fracture is happening somewhere here, above the condyles. That is why it's called supracondylar. So this in no way supracondylar fracture will affect the three bony prominences. The triangle is well maintained. If any problem happens in medial epicondyle, lateral epicondyle, or olecranon, or any problem in the joint, these triangles are altered. These triangles are altered. So a lateral medial epicondyle fracture will alter the triangle. Elbow dislocation will alter the triangle. Intercondylar fracture will alter the triangle. A olecranon fracture will alter the triangle. Okay. Now you see, decrease. This is I am going to explain. The cause for decreased length of the medial limb is posteromedial elbow dislocation. Posteromedial elbow dislocation. Increased length of medial limb is fracture of the medial condyle. Fracture of the medial condyle, what will happen? Callus will be formed. So that medial length. So this is your medial limb. This is medial epicondyle. This is lateral epicondyle. For example, you take this as medial epicondyle. This as lateral epicondyle. This as olecranon. Okay. Whenever there is dislocation, posteromedial dislocation of the elbow, this length is decreased. This length is decreased. If there is a fracture of the medial epicondyle, a callus, big callus will be formed. So this length is increased. This length is increased. Likewise, posterolateral dislocation, this length is decreased. If there is fracture of the lateral epicondyle, this length is increased. You got my point? Very simple. So increased length of medial limb, fracture medial condyle. Decreased length of lateral limb, posterolateral dislocation. Increased length of the lateral limb, fracture lateral condyle. Altered horizontal limb. For example, this is the base. This is the baseline. Whenever there is increase in this, it is intercondylar fracture. Whenever there is alteration in the base of the triangle, it is intercondylar fracture. Very simple and highly expected. Okay. CA class are so lucky. Okay, no problem. Okay, sir, not due to common or extensor origin of the pull. Okay. Supriya, you have asked a question, sir, not due to common flexor or extensor origin or their pull. Yes, Supriya, it can happen in children. When there is, Supriya, you just listen, when there is pull of the medial epicondyle, common flexor origins are there. In lateral epicondyle, common extensor origins are there. It can cause avulsion fracture. Okay, that fracture also increases length of the triangle. Okay, so this is a concept based area. Once you are understood, no need to memorize. Whatever question they ask, easily we can answer. Supracondylar fracture is condyles above the medial and lateral epicondyle. So, no way the triangle is altered. So, in our main videos and in rapid revision in other YouTube sessions, elbow dislocation, the main difference between elbow dislocation and supracondylar fracture, I have explained. In supracondylar fracture, the three bony prominences are well maintained. In elbow dislocation, the three bony, the triangle is very much altered. Okay? Yes. We will move on to the next question. Framed question. Joint that is spared in rheumatoid arthritis. Joint that is spared in rheumatoid arthritis. Yes, Tamil Maran had understood. I think Tamil Maran, you have understood. Fracture increases, dislocation decreases. That's good, Tamil Maran. That's all. That's the concept. Okay. D for D, dislocation decreases. D for D, dislocation decreases. Fracture increases the length. That's all. Very good. Super. Okay. Yes, the joint that is spared in rheumatoid arthritis. In rheumatoid arthritis will not involve. This is a very important question. I have framed this question. Then I will show you the real question. This is very important. Hey, the question is rheumatoid, not osteoarthritis. Many of you are confusing with OA. Yes, now the answer is Gracie Irudayaraj have answered it. Gracie Irudayaraj have answered this. Sadia Wani, you have answered. Rashmi, you have answered. Marvelous, man. The joint that is spared in rheumatoid arthritis is first corpo-metacarpal joint. First corpo-metacarpal joint. Now the real question they had asked in INI-CET. In an outpatient department, a female patient presents with arthritis that symmetrically affects multiple joints. Symmetrically affects multiple joints, including the wrist, hand and the feet. The patient reports morning stiffness lasting for more than 1 hour and examination reveals swollen and tendon joint. Very, very straightforward. Female patient. Okay. Yes, symmetrical joint involvement. The answer should be yes. Very good. Excellent. All of you have answered correctly. The answer is rheumatoid arthritis. Okay. Rheumatoid arthritis. Please focus your full attention. Rheumatoid arthritis. First you see this. Then I will give you the salient points. You see, arthritis, you should know osteoarthritis, rheumatoid arthritis, psoriatic arthritis. One more thing is there, ankylosing spondylitis, that is coming in a one separate topic is coming. That's why I didn't include it here. You see, osteoarthritis, joint that is characteristically involved, main joint that are involved is proximal and distal interphalangeal joint. Proximal interphalangeal joint, the nodule that is formed in osteoarthritis is called Bouchard's nodule. In distal interphalangeal joint, the nodule that is formed is called Herberdon's nodules. Don't forget this. Frequently repeated MCQ. Right. And it in osteoarthritis also involve first corpo-metacarpal joint, hip, knee and all other major joints. You know the common joint, knee joint, OA, that is okay. Involvement will be asymmetrical. Not necessarily equally left side, right side, the same joint should be involved. Okay, the joint that are spared in osteoarthritis, several times asked question, wrist and metacarpophalangeal. Very, very slippery, man. In OA, osteoarthritis, joints that are spared are wrist and MCP, metacarpophalangeal joint. Only the joint that are involved are proximal and distal interphalangeal joint, not metacarpophalangeal joint. Okay, joint that are spared are wrist and metacarpophalangeal joint. Very important. OA. Rheumatoid, it is ulta. You see here, rheumatoid arthritis, the most common joint involved is metacarpophalangeal joint. Most common joint involved is metacarpophalangeal joint, and it can involve all the major joint. Rheumatoid can involve knee joint, you know, genu valgum. You had read all those things. Symmetrical involvement always associated with morning stiffness. You should not forget the American. Please focus your fullest attention. Diagnostic, it is not typed here. I am going to tell you the diagnostic criteria for rheumatoid arthritis is American Heart Association 1987. That is the criteria still we are following. That is the best practical criteria. Asked question. Early morning stiffness of small joints more than 1 hour for 6 weeks. Okay. Small joint involvement. Third, hand joint involvement. Fourth, more than one joint involvement, one area. Fifth, symmetrical joint involvement. For example, left MCP is involved, right MCP, symmetrical joint involvement. Then positive rheumatoid factor. Positive rheumatoid factor. Then radiological signs of rheumatoid arthritis. Radiological signs of rheumatoid arthritis is periarticular osteopenia, asymmetrical joint space narrowing. Okay, so radiological. Finally, rheumatoid nodules. Rheumatoid nodules. See, I am going to tell once again. Early morning stiffness more than 1 hour for 6 weeks. Everything should be there for 6 weeks. Moreover, 1 hour for 6 weeks. Number 2, small joint involvement. Number 3, hand joint involvement. Number 4, symmetrical joint involvement. Number 5, more than one area. For example, hand means elbow, knee, something like more than one area involvement. Number 6, positive rheumatoid factor. Number 7, X-ray finding of periarticular osteoporosis and symmetrical joint space narrowing. Number 8, rheumatoid nodule. Out of 8, any 2 positive, it is called rheumatoid arthritis. It is called rheumatoid arthritis. Please don't forget this, right? The joint that are spared in rheumatoid arthritis are distal interphalangeal joint and first carpo-metacarpal joint. Please memorize these 2 things, man. 1 and 2. Please memorize this PDF. You will get the PDF. Please memorize this. Joint that are spared in OA, joint that are spared in RA, rheumatoid arthritis. Okay, right. Psoriatic arthritis, the common joint that is involved is proximal and distal interphalangeal joint, and it is called pencil in cup appearance, telescopic fingers, arthritis mutilans. Okay, arthritis mutilans, all these MCQs are coming. This psoriatic arthritis comes under seronegative arthritis. Okay, psoriatic arthritis comes under seronegative arthritis, right? Okay, gout, the common joint that is involved is first metatarsophalangeal joint, great toe. Great toe. In gout, the most common joint involved is great toe. In pseudo gout, most common joint involved is knee joint. Okay, so please, all these points are last minute revision and very important. We'll move on to the next framed question, real question. Valley, you have asked a question, sir. Permanent for OA something. You asked a question. I couldn't follow your question, man. Can you ask the question again, Valley? You asked one doubt. Permanent cure. Okay. You are asking what is the permanent cure for osteoarthritis. It is total knee replacement. It is total knee replacement. Yes. A patient having Trendelenburg gait. Which nerve is involved? Trendelenburg gait. Lurching towards one side. That's called Trendelenburg gait. Very good. Very good. Yeah, Valley. Yes. Yes. Permanent cure for osteoarthritis. It is total knee replacement. If it involves the hip joint, total hip replacement. So, arthroplasty. The permanent cure for osteoarthritis is arthroplasty, replacing the joint. Okay, yes, very good. Yes, marvelous. All of you have answered this correctly, and few have given the correct explanation also. Why there is one side lurch. Good. The nerve that is damaged in Trendelenburg gait is superior gluteal nerve. This is the question which I framed. You see the real question. What does a positive Trendelenburg gait? This is the question. See, this is the original question. Grammatically right or wrong, I don't know. But this is the question that is given INI-CET question bank. You see, what does a positive Trendelenburg gait not indicate in terms of involvement among the following? Yes. Among the following, what is the answer? Among the following, yes, very good. Most of you are given among the following except sciatic nerve. Sciatic nerve causes foot drop. It is high stepping gait. Trendelenburg gait is because of defective mechanism of abductors of the hip. Powerful abductors of the hip are gluteus minimus and gluteus medius. They are supplied by superior gluteal nerve. So the right answer is except, the answer is sciatic nerve. Good. Now you see Trendelenburg test or Trendelenburg gait. Usually we will do what is called an assisted Trendelenburg test. Okay. Positive Trendelenburg gait indicates ipsilateral superior gluteal nerve palsy which supplies hip abductors, that is medius and minimus. The superior gluteal nerve is a direct branch of sacral plexus and not related to sciatic nerve. This is the explanation. Right. Normally speaking, if my hip is healthy, both my abductors, gluteus medius, minimus, everything is healthy. If I stand on one leg, For example, I am standing now on my left leg. Right hip is elevated. Right anterosuperior spine goes up. When I flex the right knee, right anterosuperior spine, right ASS goes up. If I am having a failure of this side, affected side, for example, left side gluteus medius and minimus is weak because of superior gluteal nerve palsy. When I stand on the left side, right ASAS won't go up, it will sag down. That is called Trendelenburg sign. And whenever Trendelenburg sign is there, when you ask the patient to walk, they will have what is called a Trendelenburg gait, lurching towards the opposite side. Okay, lurching towards the opposite side. Right. Now coming to the next question, methods of, yes, lurching, drop opposite. Marvelous, marvelous. See, since you people are so much participating and involved in the class, I want to give an extra point. Trendelenburg gait, for example, lurching means where the trunk is moving, the swaying of the trunk. This is called lurching. This is called lurching, right? For example, I am having left-sided superior gluteal nerve palsy and I am having a Trendelenburg gait. When I step on the left side, my body lurches to the right. So this is called Trendelenburg gait. Okay. Otherwise, for example, I am having a severe arthritis of the left hip. Arthritis of the left hip. When I stamp, when I put my pressure on the left foot, because of pain, immediately the stand space is quick. So again I will lurch like this. That gait is called antalgic gait. So the difference between used before taking same ABG. Okay. So you are gone to the next question. Wait, man. I am here with the Trendelenburg gait. See, this is called antalgic gait. So the difference between Trendelenburg gait and antalgic gait is stand space duration is normal in Trendelenburg gait. Stand space duration is decreased in antalgic gait. You know, gait cycle, stand space, swing phase. Okay, this is how we walk. Gait cycle, stand space, swing phase. First thing is in stand space is heel strike, mid stance, toe off. Then swing phase, early deceleration, then acceleration, then deceleration. This is swing phase. This is called gait cycle. So this is when the foot is flat on the ground, this is called stand space. The stand space duration is normal in Trendelenburg gait. Stand space duration is very much decreased in antalgic gait. So the closest possible differential diagnosis for Trendelenburg gait is antalgic gait. Okay, should have this extra point. Since you are very much involved in the class, I am telling this extra point. Now let us go to the next framed question. Method to assess deep palmar arch patency using pulse oximetry. Yes. Yes. Superb. Okay. Yes. This question I have framed. This is not original question of the bank. Original question is coming next. See, this is a slippery question, dear guys and girls. Please. Method to assess deep palmar arch patency using pulse oximetry is called Barbeau's test. It is called Barbeau's test. Method to assess deep palmar arch patency clinically is called Allen's test. Now we are going to learn. Okay, this is the real question that is asked in INI-CET. What is name of the test performed in the image given below? This is called Allen's test. This is called Allen's test. Good. Okay. Yes. Allen's test. Okay. Yes. Now, please focus your fullest attention. Now we are going to discuss what are the two important tests that are available to assess the deep palmar arch patency. Deep palmar arch is formed by radial artery and deep branch of ulnar artery. Okay, deep palmar arch is formed by radial artery and deep branch of ulnar artery. So what happens? Now you compress the radial artery, you compress the ulnar artery like this, May ask him to make fist like this. You see my fingers? It is blanching. When I release, yes, the radial side and compressing the ulnar side, filling, that plethora will happen. Capillary the arterial refilling will happen. Again, next time you compress both the vessels, you blanch the fingers like this. You make a fist, blanch the palm like this. Now you release the ulnar side, press the radial side. Again, now also it is becoming pink. This indicates that your deep palmar arch is patent. This test is called Allen test. This test is called Allen test. Test to test the deep palmar arch patent clinically. Okay, clinically. This is called Allen test. Okay. Now, what is this Barbeau's test? Allen's test, this I have explained. I had shown you. Okay. No need to tell it again. What is this Barbeau's test? Barbeau's test is another method for assessing patency of the deep palmar arch. This uses pulse oximetry and plethysmography to assess the palmar arch. So in ICU, these machines are available so that they will assess. Why? Either you should do an Allen's test clinically or a Barbeau's test using this pulse oximeter before puncturing the radial artery. Because in ICU, when you want to collect an arterial blood gas sample, you will collect it from radial artery. When you puncture the radial artery, if your deep palmar arch is not patent, after pricking with a needle of the radial vessel artery, radial artery will go for spasm. If your deep palmar arch is not patent, fingers will go for gangrene. So, it is a must to record in the case sheet before puncturing radial artery. I have performed Allen's test or Barbeau's test. There is patency of deep palmar arch. There is no problem in deep palmar arch. Then only I should give a prick to the radial artery. If Allen's test is positive, okay, if Allen's test is positive, I am compressing the radial artery and leaving the ulnar vessel. There is no refilling of the vessel. That means ulnar artery is not functioning. When ulnar artery is not functioning, when I prick the radial artery temporarily will go for vasospasm. That itself, in the meantime, it can cause gangrene of the vessel. It will become a medical negligence. So it's very, very important test. That is why they are repeating this again and again. Now let us see what is Adson's test. Adson's test is to test the thoracic outlet syndrome, otherwise called a cervical rib. Ask the patient to abduct the upper limb to 90 degree. Ask him to turn the head towards the same side. You palpate the radial artery pulse. Okay. You will see, you will palpate the radial artery. Ask him to take a deep breath. If there is cervical rib or thoracic outlet obstruction, the radial artery pulsation will disappear. This is called Adson's test. This is called Adson's test. Very good. Okay. So this is called Adson's test. So Adson's test is an excellent clinical test to diagnose thoracic outlet syndrome, otherwise cervical rib. Barbeau's we had explained. Then comes Hohmann's sign. Okay. Hohmann's sign, you know, Hohmann's sign is seen in deep vein thrombosis. Okay, there are two signs in deep vein thrombosis. One is dorsiflexion of the foot causes pain in the calf muscle. This is Hohmann's sign. Okay. When you squeeze the calf muscle, it will cause pain. That is called Moses sign. That is called Moses. Moses is directly squeezing the calf muscle. Hohmann is dorsiflexing the foot. So these two signs are for DVT, deep vein thrombosis. Okay. So Hohmann's is a safe method. Moses sign, if there is a DVT, when you squeeze, no, thrombosis can go for thromboembolism. So nowadays they are not, it is not advocated practically. Now I will ask you a question. Okay, it's a time to ask you a question. Okay. Okay, time to ask you a question. You see here, various test names we had seen, no? Allen, Adson, Barbeau, Hohmann. I will ask you a question. Hohmann sign, where will you get? Extra question. Since you are participating well, man, I am asking extra question. Yes. Yes. Valley Ted, Hohmann's crunch. You are right. Sayeda, you have answered something. We are very close, Sayeda, to the answer. Hohmann's crunch. That's called Harman sign. Pneumopericardium. You'll get that is in pneumopericardium or pneumomediastinum. Not pneumothorax. Pneumopericardium or pneumomediastinum. You will get the Harman's crunch. Okay. Esophageal rupture. Rashmi, your answer is right. Esophageal rupture causes pneumomediastinum. That is why you are getting the Harman's crunch. Okay. Very good. Right. Superb. Superb. Now, one more extra question. We will go to the next. Okay. One more extra. See, Alan Adson. If I ask a question, Anton test, where you read? Because this is last resort revision, I have every right to ask from 19 subjects. Where you have read the Anton test? Coming to my MCQs, coming to my mind. Yes. Hello. Come on, cheer up, guys. Yes. Anton tests. Yeah, esophageal tear is called Boyer-Hovey syndrome, and the Boyer-Hovey syndrome will cause pneumomediastinum, causes Harman's crunch. You are right, Rashmi. Superb. Wow. Anton test. Anubhav Avasthi have given the right answer. Give her a very big hand. Anubhav, excellent. So Anton test comes in Listeria monocytogene, listeriosis. Superb. It's a micro question. Listeria monocytogene. Okay, listeriosis. Okay, listeriosis. In listeriosis, you are suspecting listeriosis in an individual. You take the blood sample, you instill the blood in rabbit's eye. Rabbit will develop immediate conjunctivitis. That is called Anton test. Okay, so today we had seen Allen's test, Adson's test, Anton test, Barbeau's test, Homan's test, Moses test, Harman sign. Okay, excellent, superb, superb. We will move on to the next question. Yes, all our signs of, yeah, it's an endotoxin test. Good. All are signs of malignant transformation of exostosis except. This is, I framed this question. And then next question, I will show you the real question. Yes. Valley is asking, sir, teach 19 subjects. We will do, man. No problem. No problem. Yes. Very good. So, all are signs of malignant transformation in exostosis except. Please carefully read the question. I have framed this question. It's very slippery. Read the question twice, then give the answer. Okay. Shall I answer the question? Anybody? Yes. Parnitkar, Sayeda, Gracia, Supriya, Anubhav, Avasti, Risha. Now everyone is coming with the right answer. Superb, great. Cartilaginous cap size more than 3 centimeters is the exception. It should not be 3 centimeter. It should be 2 centimeter. More than 2 is enough to say it is malignant transformation. Now the real question they framed in INI-CET. A 14-year-old male presents with mushroom-like tumor in the distal femur for the past 2 years. Which of the following features suggests its malignant transformation? So this is classical X-ray of exostosis, which is the classic, which suggests that it is more than, you thickness of cartilaginous cap more than 2. This is the only, and you can measure this only in MRI, man. You can't see this in X-ray because cartilage you can't see in the X-ray. Cartilage thickness can be measured only in MRI. So in MRI, thickness of cartilage cap more than 2 centimeters, it definitely says it's going for malignant transformation. Bone marrow is continuously, the parent bone is wrong. Cartilaginous growth goes towards the joint. Cartilaginous thickness more than, you see here, they are given a closed choice, 3. This is how INI-CET will frame a question. So this is very important. Please memorize this slide in the PDF. Read it twice. Guaranteed something will happen in this, in INI-CET and NEET PG. 1% chance in solitary osteochondroma, 5% in hereditary multiple exostosis. Sessile type more prone for malignancy than pedunculated type. In my main video, very detailed with animation I had taken. Osteochondroma transformed into low-grade chondrosarcomas, sudden increase in size, new onset pain without trauma, cartilaginous cap thickness more than 2 centimeter MRI. These three are golden signs of malignant transformation, and always it's confirmed only by biopsy. We'll move on to the next question. Most common cause of mortality in pelvic fracture. Again, this INI-CET is obsessed with this question. I have framed this question. I will show you the real question, the next thing. Yes. Most common cause of mortality in pelvic fracture. Marvelous. Okay. Yeah. Aliak, Supriya, Dr. Bella, Pepsi, all of you are given. Marvelous, man. Excellent. Most common cause of mortality in pelvic fracture is hemorrhagic shock. In front of you, the BP pulse, everything will go down. Front of you, hemorrhagic shock. This is the question I have framed. You see, this is the real INI-CET question. In case of an ongoing bleeding in a patient with fracture of the pelvic bone, what is the immediate action that needs to be taken to address the situation? If the patient is in hypotension, immediate thing, what will you do? So this is called ATLS protocol, Advanced Trauma Life Support Protocol. They are obsessed with this. Yes, please. Marvelous. Superb. Many of you are answering yes. Tamil Maran has answered. Sadhya, yes. Dr. Bella, yes, very good. Okay, many of you have answered it correctly. Immediately, you should load the patient with crystalloids because it is ongoing, it is hypotension, it is hemorrhagic shock. The diagnosis is hemorrhagic shock. Immediately, you should go for crystalloids. ATLS protocol. You see, this is very important, man. Please don't follow your Google or some other search. They will confuse you. This is the authenticated proper explanation from ATLS protocol. Please focus your fullest attention. A pelvic fracture case comes to you. It goes for hypotension. It is hemorrhagic shock unless otherwise it's proved. Fat embolism will happen 72 hours later. At least 48 hours later. 48 hours later. Ideal time is 48 hours. Okay, not immediately. Immediately, when RTA has happened, road traffic accident has happened, patient has severe pelvic fracture, they are bringing the case to you. In front of you, BP and pulse is going down. It is hemorrhagic shock. Immediate thing, you should do a central cannula, start the patient on crystalloids, plasma expander like dextran, crystalloids. Okay, you should try to maintain the intravascular volume. Our aim is to maintain the intravascular volume. Now, in the case of pelvic bone fracture with hypotension, the immediate next step will be administer crystalloids and stabilize the patient first. BP is a must. If it goes for cardiac arrest, what is the use of doing internal fixation, external fixation? Nothing. You maintain the ABC, airway, breathing and circulation. Okay, ABC first. Then management steps to be followed. No, after this, you assess the vital signs, initiation of ATLS protocol, administration of crystalloids. Then, since the pelvic bone is moving, it can cause venous rupture, and most of the time the bleeding will be from the venous sinus. So, you fix it with a pelvic binder. This is the next step. Pelvic binder is the next step. Crystalloid is the first step. This applied to reduce bleeding and maintain hemostasis. After that, an external fixator is tried. This is the third step. Applied patient hemodynamically stable. He should be fit for anesthesia. Then finally everything becomes alright. Hemodynamically stable. Anesthetist said that you can take the case to the main theatre. There you go and put the internal definitive fixation with a plate or whatever it is. So never forget this. Many times repeated area. Again they will ask you with a different pattern of question. Whenever a patient of pelvic fracture comes to us with hypotension, first thing I will think is a hemorrhagic shock. Hemorrhagic shock, I will maintain crystalloids, then I will apply pelvic binder, then external fixator, finally internal fixation. Okay, definitive treatment. Now we will go to the next important framed question. Look at this diagram. Identify the sign given in the image. Yes. Identify the sign given in the image. What is this classical sign called? Highly expected question. Highly expected. Yes. Yes. Look at this image. Yes. Dr. Bella has now it's giving a right answer. Bella. Akshaya have given the right answer. Yes. Saida has given the right answer. Good. Good. Okay. This classically, when you see here, something looks like this. This is called step of sign. This sign is called step of sign. I will explain to you the difference between step of sign and sulcus sign. Okay. Only confusing thing is whether this is a sulcus sign or a step of sign. I will explain to you. Okay, no problem. This is called step of sign. Step of sign. This is I framed this question. Now I am going to the real question of INI-CET. In the emergency room, a 40-year-old male patient arrived with complaint of pain and swelling in the right shoulder following a fall. The patient's X-ray indicates a tear in which of the following ligaments? Coracoclavicular, acromioclavicular, both of the above, glenohumeral. Look at the X-ray and tell. Yes. 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 Now you are answering. Likita has answered. 14 version has answered. Yes. Yes. Dr. Bella. Yes. All of you. Yes. Dr. Doom. All of you have answered it. Excellent, man. Both of the above is the right answer. Because you see, you focus your attention. This is the acromion. This is the clavicle. There's a big gap between the clavicle and the acromion. So the acromioclavicular joint is dislocated, disrupted. Disruption of the acromioclavicular joint. When you see this much gap, the acromioclavicular ligament and coracoclavicular ligament both are torn. So both of the above is the right answer. The classical clinical sign you will get, this is the radiological sign. The classical clinical sign, this is called step of sign. This is called step of sign. First, I will explain the grading of the acromioclavicular joint dislocation because this is under-read area. I am sure most of you wouldn't have touched this area. Please focus your fullest attention. These INI-CET guys somewhere obsessed around this area. They may frame a question. Please. The above X-ray indicates grade 3 injury to the acromioclavicular as per Rockwood. Grade 3 means first you should know what is grade 3. That's why I am going to teach you. In grade 3, both coracoclavicular, acromioclavicular ligaments are disrupted. Okay. You see, this is a normal X-ray. This is a normal X-ray. The points are well marked here. In the PDF, please read. Okay. The normal anatomy. Only this much distance should be there. Okay. Between the clavicle and the acromion. Now I will teach you. The classification is called Rockwood and Green's classification. 6 types are there. Type 1 means Rockwood and Green's classification. Type 1 means only sprain of acromioclavicular ligament. No disruption anywhere. Just sprain of acromioclavicular ligament. In that you will not get, in the X-ray you won't get any finding. Patient will complain only of pain. Because there is no tear of the ligament. There is only sprain of the ligament. So, treatment of choice is conservative. Just give an arm slab. Don't mobilize the shoulder for a week. Give painkiller. That will become alright. Type 2 acromioclavicular joint injury is acromioclavicular disruption. Acromioclavicular ligament disruption. Coracoclavicular ligament is intact. Only acromioclavicular ligament is disrupted. Coracoclavicular ligament is intact. Okay. For this also you can treat it conservatively. Give rest. If pain persists more than 6 months, only surgery. This is type 2. Type 3, both acromioclavicular and coracoclavicular ligaments are disrupted. Only in this type you will get the step of sign. Step of sign, and you will see an X-ray like this, big gap is there. When both acromioclavicular ligament and coracoclavicular ligament both are injured, only treatment is surgery. Only treatment is surgery. Okay, I will tell the surgery name also. You see here. What we will do, I will fix this clavicle to the acromion and I will put a screw and fix it to the coracoid. This is here shows the coracoid process somewhere here. I will fix it with a screw in the and fix it the coracoid process. This is called Bosworth procedure. Bosworth. Okay. This is called, I will write it once again. The treatment of choice type 3 is AC plus EC. No, best treatment is surgery. That is called Bosworth procedure. Bosworth procedure. This is the treatment of choice. So far unasked in any of the Indian entrance, but it is there in all the standard textbooks. So this is type 3. This is type 3. Okay. Type 4. This is very severe type. Acromioclavicular ligament, coracoclavicular ligament, deltoid trapezius aponeurosis are disrupted. Distal end of clavicle pierces the distal end of the. Hello, sir. Please correct the order of lecture in the app. What is you're asking? What is that? Please correct the order of lectures in the app. Muhammad, you have given some this thing in the message. I will come to you later. Order of the lectures in the app. Okay, Muhammad, at the end of the session we will discuss this. Okay, I have given the correct order. I don't know how they had uploaded. Again, I will. Okay, okay, right. See, type 4, it is acromioclavicular. Muhammad, I will come to you at the end. Okay, I will come to you at the end. Okay, you please be there in the lecture in our YouTube. At the end, we will discuss and I will make the arrangements for you. No problem. See, AC plus everything disrupted the distal end of clavicle pierces the trapezoid. Okay, so treatment of choice is surgery. Type 5, very severe form of type 3. Again, treatment is, for all the treatment, best is that Bosworth technique. You remember that word, right? So this is about acromioclavicular joint injuries. AC joint injury, the point I want you to know is, when you are seeing a gross difference between gap between the distal end of the clavicle and the acromion, it is type 3 and above. Type 3 and above, treatment of choice is surgery. The best surgery is Bosworth technique. Till type 2, that much gap won't be there. Clinically, step of sign won't be there. So type 1 and type 2 can be managed conservatively. Okay, conservatively. 1 minute, I will change the slide, PDF. 1 minute, be with me. Yes. Yes. 1 minute, 1 minute. Indian. No. Yeah. Okay. You know? One minute. First one. Okay. Yes. Okay. Right. Okay. So, okay, yeah, version, yes, I said that I will differentiate between the, I had forgotten, I differentiate between the sulcus sign and step off sign. Please focus your fullest attention. I had forgotten. Thank you, version, for for reminding me. Yes, you see here. See what is the step off sign? When the patient stands like this, you will see a step off like thing, a gap between the distal portion of the acromion and the head of the humerus. Easily you can see like that. In sulcus sign, normally you won't see anything. Sulcus sign, normally you won't see anything. You should make the patient flex the elbow, pull the elbow down, give traction. Here a sulcus will be formed. When you relieve the traction, that will go. That is called sulcus sign. Sulcus sign is a sign of recurrent shoulder dislocation. Sulcus sign is a sign of recurrent shoulder dislocation. Step off sign, whether you pull or not, if it goes to type 3 acromioclavicular joint injury, it will show you. In sulcus sign, normally you won't see anything. Only in the lateral angle, make the patient like stand laterally like this. You be here, give traction. In here, you will see a sulcus will come when you give traction. When you relieve, that will go away. So that is seen in recurrent shoulder dislocation. Thank you for reminding me. Yes. Thank you, Varshan. Yes. We'll move on to the next thing. Hawkins sign is a good prognostic indicator, bad prognostic indicator, nil significant, seen in calcaneal fracture. Yes. All of you have Tamil Moran already, all of you have already answered it. Excellent. Pepsi, all of you, Anubhav, already you have answered. Very good. Hawkins sign is this. I framed this question. I will show you the real question. It's a good prognostic indicator. I will explain what is this. Now this is the real INI-CET question. For which type of fracture does the Hawkins classification apply? The answer is yes. Yeah, you said Oishi has given it little bit look like a regimental patch. Regimental patch sign is totally different, man. Regimental sac, you won't see sulcus or groove like that. Regiment patch sign is loss of sensation over the deltoid. Regiment patch sign is loss of sensation over the deltoid. Okay, that is seen in anterior shoulder dislocation because of axillary nerve compression. Yes, good. All of you have answered it correctly. The answer is talus. Okay, Hawkins classification is for talus. Okay, now you see talus fracture. See, leave this. Okay, I will tell you. Please focus your fullest attention, because since you people are great people, participating very well, encouraging me, I have to do real LRR. Focus your attention. The classification system for clavicle, Allman. The classification system for proximal humerus, Neer. The classification system for distal humerus, that is supracondylar, Gartland. The classification system for radial head, Mason. The classification system for distal radius, Freichmann and Fernandez. The classification system for neck of femur, Gordon's. I am telling only the standard. Powell's is there, Delbert is there, Gordon's. Okay. The classification system for proximal tibia, Schatzker-Tile. The classification system for calcaneum, Sanders. The classification system for talus, it is Hawkins. Okay. Few classification systems we have revised. Okay. So one more time I will tell, you revise along with me. The classification for clavicle, Allman. Proximal humerus, Neer. Supracondylar, Gartland. Radial head, Mason. Distal radius, Freichmann and Fernandez. For neck of femur, Gordon's. Proximal tibia, Schatzker-Tile. For this calcaneum, Sanders. For talus, it is Hawkins. Okay. So I used to teach yes, clavicle, Allman, very good, Valabi. So I used to teach my students, UG students in my college, I used to teach them for a joke purpose like this. Wherever a word Hawkins comes, that question is about talus. Okay, wherever. Hawkins angle is fracture angle of talus. Hawkins classification is for fracture talus. Hawkins disease is avascular necrosis of talus. Avascular necrosis of talus is called Hawkins disease. Okay, so like that, wherever Hawkins sign is a good prognostic indicator in talus fracture. So wherever word Hawkins comes, it is talus. But never in your, because you are going to write 19 subjects. Hawkins Surya, don't write passage of talus in urine. I used to, in a joke fashion, because Hawkins urea is a biochemical metabolic inborn autosomal dominant inborn error of metabolism of tyrosine. Okay, Hawkins urea, that is a different condition. Okay, HDP, that is deficiency in tyrosine metabolism. The classically Hawkins urea, the smell of the urine is called swimming pool odor. Swimming pool odor. Swimming pool odor is, what does they mean? Swimming pool odor, chlorine smell in urine. Okay, Hawkins urea. Okay, good. Yes, very good. Tyrosine, marvelous. Okay, superb. You are in groove. Now, what is this Hawkins classification? Type 1 undisplaced. Type 2 means talar neck plus subtalar dislocation. Type 3 means talar neck, subtalar dislocation plus ankle dislocation. Type 4 means talar neck plus subtalar dislocation plus ankle dislocation plus talonavicular dislocation. 4 things. Okay, 1, 2, 3, 4. PDF will come. Please revise once. That is enough. Treatment for undisplaced. Why you are classifying undisplaced? That is type 1 conservative, POP. More than type 1, type 2, type 3, type 4, open reduction internal fixation with a screw. Now you see the main complication in type 1 and type 2, avascular necrosis is only up to 50%. Type 3, type 4, the chance of AVS is 100%. 100%. Okay. And what is this Hawkins sign? Please focus your fullest attention on this diagram. You should zoom your app and you should see. Subchondrally, the arrows, no, I am able to see. I will draw this and I will erase that red line. You see, subchondrally, I am able to see a translucent line like this. Translucent line like this. This translucent line is called Hawkins sign. When you see a translucent line in the subchondral area, it says the bone is metabolically active. That means bone is living. So when you see Hawkins sign, the chance of AVN is very less or nil. So it is a good prognostic indicator. In all talus fracture, in the follow-up after 2 weeks, we will take the proper view and we will look for Hawkins sign. When Hawkins sign is there, it's a good sign. That means the bone is metabolically active. That means bone is alive. It won't go for AVN. Okay? Yes. We will move on to the next question. Most common site of osteogenic sarcoma. This is a child's play. Everyone knows it is knee joint. But the doubt is whether lower end of femur or upper end of tibia. Because lower end of femur and upper end of tibia both are knee joint. There comes the problem. Yes. Most common site of osteogenic sarcoma. Please participate. Yes. Very good. Very good. All of you have answered it correctly. Lower end of femur. This is the most common site. This is upper end of tibia is the second common site. Okay. Osteogenic sarcoma. Now the real question what they had asked in INI-CET. A 10-year-old boy is experiencing pain in area surrounding his knee joint. Following lesion visible on the X-ray is seen extending from the distal femur to the terminal end. What is the most likely diagnosis? This is the classical sunburst appearance, man. This is the classical sunburst appearance. So this is a case of osteogenic sarcoma. Okay, osteogenic sarcoma. Right. D. Yes. Pooja. Yes. G Bank. Okay. All of Pepsi. Good. Now, based on the demography of the patient, that is the area which is involved, clinical manifestation, X-ray showing sunburst appearance, most probable diagnosis osteogenic sarcoma, most commonly arises in the metaphysis of the long bone. So 10-year-old is little young. This is the only thing which is, this is little young. This is the only thing which is against. But all other things are there for osteogenic sarcoma. Now I will tell you the salient point. Osteogenic, please focus your fullest attention. I can't, oh, it is not D bank. Okay, yes. You please focus your fullest attention. Osteogenic sarcoma is the second common primary malignant bone tumor. First common primary malignant bone tumor is multiple myeloma. If they ask the question, most common primary solid malignant bone tumor, then it is osteogenic sarcoma. Otherwise, most common non-hematological primary malignant bone tumor, the answer is osteogenic sarcoma. Okay, so please focus your fullest attention. Again, I will tell you, most common malignancy of bone are secondaries. Primary malignancy, most common primary malignant bone tumor is multiple myeloma. Second common primary malignant bone tumor is osteogenic sarcoma. Most common solid primary malignant bone tumor is osteogenic sarcoma. Most common non-hematological primary malignant bone tumor is osteogenic sarcoma. Osteogenic sarcoma happens in the metaphysis. It arises from multifactorial mesenchymal cell. Age group is usually second decade. More common on male patient. Most common site around knee joint, that is distal end of femur. Osteogenic sarcoma, the secondary osteogenic sarcoma, the most common primary that cause the primary disease which can cause secondary osteogenic sarcoma is Paget's disease. Paget's disease. You should remember, all these are very important. And osteogenic sarcoma, the chromosomal anomaly is 13q14. Q means long arm. 13q, Robbins says 13q14. That is called RB gene, retinoblastoma gene. For retinoblastoma also, the same chromosomal thing is 13q14. That is why those who develop osteogenic sarcoma, more chance of developing retinoblastoma. Those who develop retinoblastoma, more chance of developing osteogenic sarcoma. Treatment of osteogenic sarcoma, Codman's triangle, sunburst appearance. Osteogenic sarcoma, treatment of choice is surgery, surgery, surgery. Surgery is the primary treatment of choice. Okay. If they give a thing in the choice, surgery is there in the choice, combined approach, combined therapy, something like there in that choice, you should go for that. Because latest apply says pre-op radiotherapy, then amputation followed by post-op chemotherapy will improve the survival rate. So combined approach, if there in the choice, they are asking for that. Okay. So you should recollect all these points. Okay. While doing, we will go on to the next. Yes. Paget's disease. Yeah. Right. Yeah. Dr. Bella has asked a question. Yes. Most radio-resistant bone tumor is osteogenic sarcoma. Most radio-sensitive bone tumor is Ewing sarcoma. Okay, most radio-sensitive is Ewing sarcoma. Ewing sarcoma happens in young age, 10 years of age. It happens in the diaphysis. It happens in the diaphysis. Osteogenic sarcoma forms true rosette. That is called flexner intestinus rosette, like retinoblastoma. Ewing sarcoma forms pseudo rosette, which is called Homer Wright rosette, which is seen in neuroblastoma. So, Ewing sarcoma patients more chance to develop neuroblastoma. Neuroblastoma patient more chance to develop Ewing sarcoma. All these are Robbins points. Excellent. Okay. Superb. Right. Yes. Ewing sarcoma. D-Bank Das has used the word Ewing sarcoma treatment of choice. Treatment of choice for Ewing sarcoma. It is more radio sensitive. It will melt with radiotherapy. That's okay. But again, treatment of choice for Ewing sarcoma is again surgery, not radiotherapy. That's the catch. Very good, man. Superb. We'll move on to the next question. A patient had a hip dislocation, got treated. He developed weakness of the quadriceps. He complains of difficulty climbing stairs. What kind of dislocation would have he got? I framed this question. Again, another very important. Yes. Answer please. Okay. Okay. Yes. Yes. Monica have answered it correct. Yeah. Monica Patidar. Right. Hey, Monica Patidar, like RCB name, man. Monica Patidar has given the right answer. Marvelous. Schnomlun. The names you can make. Okay, you can have a very simple name, no? As the handle. You see, yes, good. Most of you have answered it correctly. Gracia, you have answered it correctly. It is anterior dislocation because this implies femoral nerve involvement. This implies femoral nerve involvement. Quadriceps damage, quadriceps weakness. That is why he developed difficulty in climbing. Anterior dislocation causes femoral nerve injury. This is the original question asked in INI-CET. What could be the potential diagnosis for a 22-year-old male patient presenting with a history of accident exhibiting leg abduction and external rotation? Abduction, external rotation. It should be anterior. Very good. Oishi, yes. Okay. Yes. Yes. Anterior dislocation of the hip. Very good. Okay. Excellent. So, abduction, external. You see this slide. So, we are going to complete hip dislocation in 1 minute. Revise hip dislocation in 1 minute. Posterior dislocation hip. Mechanism of injury. Dashboard injury. 1 lakh time repeated question. Dashboard injury. Classical attitude of posterior dislocation hip. Flexion, adduction, internal rotation. Flexion, adduction, internal rotation. Okay. Marked shortening of the leg. The nerve that is commonly involved is sciatic nerve. So, foot drop. Posterior dislocation. Vascular sign of North positive. Okay. You know what is vascular sign of North. Palpating the femoral artery pulsation is feeble or absent. That's called vascular sign of North positive. Exact anterior dislocation mechanism of injury is air crash. I used to teach my UGs always posterior dislocation is a middle class injury. Anterior dislocation is a costly injury. Air crash. Okay. Then classical attitude is flexion, abduction, external rotation like this. There is lengthening. Here the nerve that is damaged is femoral nerve. That is why quadriceps involvement. Okay. Vascular sign of North is negative. Central dislocation of hip. Central dislocation. There are 3 types of hip dislocation. Anterior, posterior. And most common type is posterior. Central dislocation, head, it pierces the acetabulum, goes into the pelvic cavity. In central dislocation of hip, the attitude of limb is unaltered. You can't see anything. Only thing when you do a perrectal examination, you can palpate the head of the femur easily perrectally. That's all. Okay. Yes. Very good. Yeah. That is what your Anubhav. That's called Fadir and Faber. Flexion, adduction, internal rotation. Flexion, adduction, internal. Fadir, that is Faber. Flexion, abduction, external rotation. The mnemonic what we use, no, in our main recording it is there. It is called flexion, adduction, internal rotation. This is called Fadir. This is flexion, abduction, external rotation. Faber. This is the mnemonic. Good. Yes. Yes, we will move on to the next question. Yeah, the findings, no? One should not, in hip dislocation, Shenton's line. This word is very important. Shenton's line. Shenton's line. You just see the pubic rami. You draw a line along the inferior border of the superior pubic rami. It should go to the head, the neck, forms a smooth curve. So this line is called Shenton's line. If, for example, this is a case of posterior dislocation hip, this is posterior dislocation hip. This is image of anterior dislocation hip. This is image of central dislocation hip. Central dislocation. 3 types I had given the X-ray. When I draw this line on the superior pubic rami, the Shenton's line, I am not able to complete. The Shenton's line is broken. In anterior also, you see in normal side when I draw, I am able to draw it correctly. In the abnormal side, no, it is broken. Here you see, in the normal side, this is okay. In the abnormal side, it is broken. So, Shenton's line is broken in all the 3 types of dislocation. It is broken in fracture neck of femur. It is broken in DDH. Shenton's line is broken in DDH, fracture neck of femur, all kinds of dislocation. Okay? Yes. Now, coming to the next area. This again an obsessed area in case of INI-CET and NEET PG. How long compression is given in Durkheim's test? We all know Durkheim's test is an important test in carpal tunnel syndrome. Median of compression. Okay, how long this is? Yes. Can anyone answer? How long compression is given to Durkheim's test? Please come on. Yes. Gracie, you have answered it correct. Yes. Monica, Patidhar, Pepsi, Pooja, Akshay, Sunil, very good man. Rashmi, excellent. All of you have given it. The right answer, should compress for 30 seconds. Okay. So now I am going to teach you the difference between Durkan's test and Fallon's test. This is the real question that is asked in INI-CET. What is the most specific test used to diagnose carpal tunnel syndrome? When you see, he has given Durkan, he has given Fallon. Both the tests are for carpal tunnel. He has given both and he is asking which is specific. The answer is Durkan's. Durkan's is specific. So this is the catchy area. Now I am going to explain. You see here, Durkan's test, other name is carpal compression test. Fallon's test is wrist flexion test. Here the examiner, Durkan's test, you look like this. Directly I am compressing the median nerve for 30 seconds. For 30 seconds. Okay, direct compression. In Fallon's test, I am flexing the wrist like this and I should keep for 1 minute, 60 seconds, 1 minute. Okay. So when you flex the wrist joint, that increases the pressure in the carpal tunnel and checking. But in Durkan, it is directly compressing the median nerve. So Durkan's is more specific, more sensitive than Fallon's test. This is the catchy area. Okay. I think we have got the concept. We will positive this is okay. Specificity is good. And times of symptom 30 seconds is sensitivity usually higher. This is moderate. Okay. So sensitivity of Durkan is very higher. That is why that is a superior test. Okay. Like our Latchman and anterior drawers. Both the tests are for anterior cruciate ligament. Latchman is superior to anterior drawers. Like that, Durkan is superior to Fallon's test. Good. Now we'll go to Bombay niger sequestrum is seen in. This I have framed the question. The same area I will show you the INI-CET question. Bombay niger sequestrum is seen in. Yes. Hello. Yes. Very good. Very good. Superb. All of you have answered. Everybody easily you have answered. That's great, man. Bombay niger sequestrum is seen in fungal osteomyelitis. The question they had asked in INI-CET is ring sequestrum is seen in. This is the question. Ring sequestrum is seen in. In 1 minute we are going to thoroughly finish the sequestrum. Don't worry. Okay. Yes. Ring sequestrum is seen in pin. Yes. Superb. Okay. Yes. It's me. It's me. The name is it's me. All of you have answered it correctly. Yeah. Pin tract infections. It is in pin tract infection. Now, you see, dear friends, please focus your fullest attention on me. Okay. You will get the PDF. You are going to read. You focus your fullest attention on me. You see, sequestrum is defined as a dead bone surrounded by a living bone. Sequestra means stand apart. That's the meaning in Latin. This is a dead bone surrounded by a living bone. That's a sequestrum. Whenever a word sequestrum comes, the only diagnosis in the whole world is chronic osteomyelitis. In acute osteomyelitis and subacute osteomyelitis, there is no such word called sequestrum. Whenever a sequestrum comes in the question, it is only chronic osteomyelitis, no other DD, no acute, no subacute business. The sequestrum, usually it is defined, it is compared with a chalk piece powder or a fish bone. Chalk piece powder or fish bone coming out in the discharge through opening in the living bone, involucrum, that's called cloaca. That opening is called cloaca. Through that it will come in the sinus. The discharge, you can see a chalk piece like granules or a fish bone. This is normal. But in certain situations, certain special types of sequestrum are happening. Normally in Staphylococcus aureus is the causative organism. You will get a fish bone like or a chalk piece granule like you will get a sequestrum. Ivory white in color. This is normal. Okay. In certain special situations, you will get special sequestrum. So sequestrum is classified according to shape. Okay. According to consistency, according to color. Okay. So you see, according to shape, you can get a pencil-like sequestrum in case of infants only. Because in an infant, osteomyelitis means everyone knows it will affect only the metaphysis. In infant, it will involve the diaphysis also. So the whole diaphysis is like a sieve, when it's like a sleeve. When it comes out, it look like a pencil. So pencil-shaped sequestrum only in infant. Ring sequestrum, pin tract infection. Conical sequestrum, amputation stump. Coralliform, like a sea coral, you are getting a sequestrum only in Perthes disease. You know Perthes disease, the full name is leg calf Perthes disease. Perthes disease is avascular necrosis of head of femur in a child. Avascular necrosis, head of femur in an adult is called Chandler's disease. Totally that is different. Perthes disease. So, only in that condition you will get coral-like sequestrum. A buttonhole-like sequestrum you will get only in radiation. Okay, this is according to shape. According to consistency, when you touch the sequestrum, it is dark brown in color and sticky like a coal tar. Coal tar is called coke. Coke means immediate thing that comes to our mind is our drink. See that drink, that coke particular drink, when you spill it in the table, you just touch after 10 minutes, it will be dark brown in color and it will be sticky like a coal tar. Since it's looking like a coal tar, they had named that brand as a coke. Originally, coke means coal tar. So exactly you are getting a coal tar like or coke like sequestrum. It is tuberculosis osteomyelitis. You are getting a sequestrum which is either like a flake or feathery in consistency, like a feather in consistency, tuberculosis osteomyelitis. Sandy sequestrum is divided into fine sandy viral osteomyelitis, very rare. Coarse sandy tuberculosis. Ivory like sequestrum, it is syphilis. Then coming according to color, black or Bombay Niger sequestrum, fungal infection. Green pseudomonas, fungal especially aspergillus niger. And green color pseudomonas. One special form of sequestrum. How many slides are left, sir? Very few slides. Okay, very few. Pooja, exam is coming, man. Pooja, you have to be with me for another 15 minutes. You should be with me. Okay, exams are fast approaching, right? Yes. See, special forms. Kissing sequestrum. Only one special sequestrum, which is kissing sequestrum. This is seen only in peridiscal tuberculosis. See, caries, that is called pot spine. Peridiscal means upper lower border, for example, L3, L4. Two vertebral bodies are affected with pot spine. L3, L4. Lower part of L3 and upper part of L4 both will touch and that will form a sequestrum, and that is called kissing sequestrum. Whenever a word kissing sequestrum comes, the only diagnosis in the world is pot spine. It is pot spine. Okay, that completes this question. We will go to the next, very important again. Okay, yes. Okay, yes. Hey Pooja, are you with me? You should not leave, man. Pooja, how many slides? Pooja, give me a thumbs up sign. Then only I will. Yes. Okay, right. Okay, yes. You see, best brace used in post-operative case of spine fracture. Best brace. Okay, yes. Okay. Best brace used in post-operative cases of spine fracture. These again and again they are giving images of these 4 braces and they are asking where it is used, Very simple, man. Best brace in post-operative. Yes, most of you have answered it correctly. Excellent. In post-operative spine, the best brace is Taylor's brace. Best brace is Taylor's brace. Right? You see here. This is the real question they are asked in INI-CET. The brace shown in the image is, what is this? They asked the question. This is called Milwaukee brace. Now, okay, yes, Milwaukee brace. You see, please, in 10 seconds, 4 important braces often repeated. You can see image based. This brace is called, whenever they give a brace like this, you see from chin, it starts from the chin, it's going up to the lumbar level. This is called, this is front side, that's back side. You see back side till occiput it is coming, here it up to the lumbar level. Okay, you see the Milwaukee brace is used for structural scoliosis. Very favorite INI-CET area. Somebody is having a lateral bending of the spine. Best brace to correct the structural scoliosis is called Milwaukee brace. Boston brace is used for low lumbar curve scoliosis. Lumbar scoliosis, this can be used, but does not include a head or chin support. Here we had seen up to the chin. Here you see the brace is only from the level of the thorax to the lumbar level. So this is called Boston brace. This is called Boston brace. Taylor's brace is used for spinal fractures or post-operative. I had done a surgery in the spine. When I discharge the patient, for a month, I will give spine support with this classical brace. This is called Taylor's brace. Very practically used thing in our ortho spine surgery. So post-operative spine stabilization, okay, or somebody has sustained spine fracture, the brace that is given is Taylor's brace. Ash brace, it's called anterior spinal hyperextension brace, used to provide hyperextension support for the lumbar spine, but it is not used for scoliosis. Patient is having kyphosis. To give hyperextension support, I will give this brace, and this is called Ash brace. This is called Ash brace. We will go to the next question. All are indications for surgery. This again a very important thing. A very important thing. The indication for surgery in spot spine. The indications are divided into indication for surgery with neurological deficit, without neurological deficit. Okay. So this I framed this question. Next question is the real question of INI-CET. Yes. Yeah. Very good. Syed have given answer. Aishi had given the answer. Shubhi had given the answer. Pooja is there. Okay. Pooja has given the right answer. Very good, Pooja. Superb. Okay. Pooja, great. So it is except is paraspinal abscess. Except is paraspinal abscess. You see here. This is the real question of INI-CET. All of the following are indication for surgery in patient of pot spine except doubtful diagnosis, cold abscess without neurological complication, drug resistant progressive carda equina syndrome. What is the answer? Yes. Okay. Drug resistant. Okay. Good. Drug resistant TB. Okay. Drug resistant TB. Now you see. Please. A PDF will come. I will read it once and I will go to the next question. Guaranteed area. Indication for surgery in pot spine. Indication for surgery in patient without neurological deficit complication. This is with neurological complications. The patient is coming, it's a case of pot spine. When he is coming to you, he is not having any neurological deficit. When will you operate? Progressive bone destruction despite proper ATT, failure to respond to conservative therapy, paravertebral abscess. This is the golden point. Patient is having paravertebral abscess, but patient is not having neurological deficit. You should go for surgery. Then spinal instability caused by destruction or collapse of the vertebra, prevention of severe kyphosis in young children, large paraspinal abscess. The same thing, paravertebral, paraspinal abscess. Indications for surgery with neurological. Patient is coming to you with some neurological deficit, new or worsening neurological complication, paraplegia of rapid onset or severe paraplegia, late rapid onset paraplegia, late onset paraplegia, neurologic disease, painful paraplegia, spinal tumor syndrome, epidural spinal tuberculoma. Epidural spinal tuberculoma. You have to go for surgery. Please read this. This is a concise, correct indications from standard textbook. Please confidently follow this. Read it twice or thrice. Go to the next question. Suturing is fruitful in which part of, we are having 2 or 3 questions. That's all. We are going to finish. 2 or 3 questions. We are going to finish. Suturing is fruitful in which part of menisci? Yes. Yes. Epic age, when LRR will come for FMGE, they will announce, okay, we will do a very good LRR, don't worry. Yes, yes, suturing is fruitful in which part of menisci? In only one part. Menisci is divided into 3 zones, man. Only in one zone, suturing is fruitful. That is red zone. I will show you the diagram, red zone. This is, I framed this question in the area. The real question of INI-CET. Which zone demonstrate most optimal healing in repair of a meniscal tear? Red zone, white zone, gray zone. The answer is red zone. You see here, when you take a menisci, the innermost zone, this is called white zone. The second zone is called red-white zone. The outermost zone is called red zone. Overall, the menisci is poor in blood supply. The outermost portion, which is called red zone, has some blood supply. So whenever some injury happens there, it will get healed. This is the concept. And this classification, the beautiful animation is there in our main video, O'Connor's classification. That's called O'Connor's classification. It's there in the main video. You see, when can you do conservative management for meniscal injury? Incomplete meniscal tear, small stable tear without ACL injury, a stable vertical zone in red zone. Here you can try non-operative management. Non-operative management means just give some knee brace, ask them to do a cold chain physiotherapy, that is quadriceps strengthening, that will become all right. When patient complains of mechanical symptoms, okay, what is mechanical symptom? Locking, popping, clicking. 3 rhyming words. Locking, popping, clicking. See, meniscal injury. See, dear guys, in clinics, this is very important. Please focus your attention for 10 seconds. Mechanical symptom is a word reserved only for knee joint. In no other place in ortho, they will teach a word called mechanical symptom. Mechanical symptom is a word that is it is restricted to knee joint, especially meniscal injury. What are the 3 mechanical symptoms? Locking, popping, clicking. Locking means, for example, I am flexing or extending the knee. Suddenly, for few seconds, knee got struck. Then with force, I continue to flex. That is called locking. Second thing, I am sitting standstill, absolutely not moving my knee joint. 0% movement, complete standstill of my knee joint. Patient is perceiving something popping inside the knee. Okay, popping means top, something like that. You know, in a corn, it is called a corn. When you put it in a hot, that machine, it will pop out, top. That's called popcorn. Like that, a patient is perceiving something popping inside the knee. That is called popping. During standstill, patient is not moving. The knee joint is standstill, but patient will perceive something bubbling inside. That's called popping. Third thing, when I am slowly flexing or extending, I am perceiving a sound inside the knee joint. That is called clicking. So clicking happens during movement, popping happens during standstill, locking is sudden striking. These 3 symptoms are called mechanical symptoms. When somebody complains of mechanical symptoms, menisci is gone, is damaged. So, when patient complains of mechanical symptom, any one of the mechanical symptom, it is an indication directly for surgery. You should not try conservative method. What are the surgeries that are available? Usually surgery, arthroscopic meniscal repair means suturing. This is done, indicated only vertical longitudinal tear in the red zone. This is the MCQ they had asked. Okay. The next thing, usually, since in the other regions, red-white zone or white-white zone, when you suture, it will never get healed. So, no other go, you have to remove a part of the menisci. That's called partial meniscectomy. So, in all other zones, only thing what you can do is partial meniscectomy. Partial meniscectomy. So, what are the surgeries that are available? Either I have to remove the menisci or I should repair the menisci. The only indication for repair means suturing, is any tear in the red zone. This is the question they are asking. That's all. This is the concept of meniscal injuries. We'll go on to the next question. Match the following deformities. Where will you get dinner fork, garden spade, humpback, piano key? Yes. Dinner fork deformity you will get in Colles fracture. Garden spade deformity you will get in Smith fracture. Humpback deformity you will get in displaced scaphoid fracture. Piano key sign you will get it in Galliesi fracture. You will get it in Galliesi fracture. Okay, good. Superb, super. Right, marvelous. Now, the question they had asked, real question, INI-CET, a female patient presents with a history of fall few months back, presents with deformity shown in the image. Probing into history reveals it was managed with traditional treatment. This deformity is likely to be due to. This is the classical dinner fork deformity. Dinner fork. It is due to, yes, marvelous. All of you have answered, everyone has answered. Extra-articular fracture of the wrist. Okay, extra-articular fracture is called Colles. Okay, so Colles, you see, dear friends, distal radial fractures can be of 5 types. It can be Colles, it can be Smith, it can be volar Barton, it can be dorsal Barton, it can be radial styloid. 5 fractures happens in the distal most portion of the radius. When it is extra-articular, it is called Colles. When it is intra-articular, it is called Barton. It is called Barton. So purely extra-articular is called Colles, and Colles will cause the dinner fork deformity, classical dinner fork deformity. The 6 components of Colles, one should not forget, very favorite INI-CET area, the mnemonic which we will teach is called Dill's mnemonic. Okay, one is dorsal tilt, then dorsal displacement, then called impaction, then lateral tilt, lateral displacement, and finally it is supination. Okay, finally it is supination. Dinner fork deformity is because of dorsal tilt and dorsal displacement. If it is ventral tilt and ventral displacement, that is called reverse Colles or Smith fracture, you will get Gordon spade deformity. Okay, pain and swelling. So this is the this is called dinner fork deformity, and one should not forget 100% positive classical clinical test. It is there in all the standard textbooks of ortho. So far unasked in any of our Indian entrance. This is called styloid process test. Without X-ray, you can diagnose Colles fracture. To be very honest, Colles fracture was scientifically invented by Abraham Colles. Abraham Colles invented this fracture before invention of X-ray. X-ray was not invented when he described all these things in Colles fracture. That is the greatness of Sir Abraham Colles. Should not call him Abraham Colles, Sir Abraham Colles. Okay, so it's called Colles fracture. So you and me also, he has taught us how to diagnose. You palpate the radial styloid, you palpate the ulnar styloid. Radial styloid is normally 1.5 centimeter distal to the ulnar styloid. This is normal. When radial styloid and ulnar styloid are at the equal level, that's called positive styloid process test. Diagnosis is extra-articular distal radial fracture, that is Colles fracture. Okay, yes. Now we will go to the next question. One of the radiological signs of supracondylar fracture is seen in AP view. All the 4 are radiological signs of supracondylar fracture. Only one is seen in the AP view. All the other 3 are seen in the lateral view. That's the question. Just I want to check how you understood this thing. Yes? Marvelous. Marvelous. Yes. Shubhi, Dhanush, all of you. Dhanush, Pepsi, Monica, okay, Anubhav, all of you, XYZ, okay, Ashraf, all of you have answered it correctly. Great. So the only radiological sign that is seen in AP view is fishtail sign. All other things are seen in the lateral view. This is, I framed this question. You see the real question of INI-CET. Fishtail deformity is seen in which fracture? Okay, it is seen in distal end of humerus. That is supracondylar fracture. Distal end of humerus, that is supracondylar fracture. This is the original INI-CET question. Okay, very good. Yes, it's maybe all of you have answered. Now you see, please, in 10 seconds we will finish these 4 signs. Okay, this is, you focus your fullest attention, man. This is a lateral, I think I am visible. Okay, I think I am visible. This is normal X-ray. Normal X-ray lateral view of elbow joint. Okay, I am seeing something. This is the capitulum. This is distal radius. This is your Olecranon process of the ulna. This is radial head. This is a normal X-ray. When I see here, I am able to see a gas shadow like thing here. This is called fat pad sign. Fat pad sign. Lateral view. Here, see, this is a normal teardrop. Normal teardrop. Here that normal teardrop sign is broken. Teardrop sign is everything in detail. It is there in our main video. Teardrop sign is broken. Okay. So this is again lateral view. Teardrop sign broken is the second sign. This is the first sign. This is the second sign. Lateral view. The third thing, normally there is a radiolucent gap between the capitulum and the olecranon. Here when you see the capitulum overlaps the olecranon, gives a crescent shaped shadow. I will see here like a moon, crescent shape. This is called crescent sign. This is called crescent sign. Again lateral view. Here when you see, this is the distal fragment. This is the proximal fragment. The distal end of the proximal fragment looks like a fish tail. This is fish tail sign. AP view. So all the signs are in lateral view. Only gunstock deformity is clinical. Gunstock deformity is clinical. Okay. So all the signs are seen in the lateral view. The only sign that is seen in AP view is fishtail sign. So one should not forget what are the signs, radiological signs of supracondylar fracture. A fat pad sign, a broken teardrop sign, a crescent sign and a fishtail sign. 4 signs are there. The most reliable sign is fat pad sign. This is the most reliable sign. Okay, if they ask a question, they are given all the signs, all the 4 signs are there in the choice. They are asking which is the most reliable sign. It is fat pad sign. It is fat pad sign. Now we will go to the next thing. Which of the following is bone cement? I think 2 more questions. Which of the following is the bone cement? Yes. Which of the following is bone cement among the 4? Yes. Dibankti Das. Das have given the right answer. Bella has given the right answer. Yes. Danusha, Gracie, all of you have given the right answer. Good. Okay. The bone cement is polymethoxymethyl acrylate. Polymethoxy PMMA. Polymethoxymethyl acrylate. This is the bone cement. This is the question I framed from the area where they ask the choices. This is the real INI-CET question. Which of the following substance is used for bone formation in patient with non-union? It is, yes, yes, very good. Yes, many of you, yes. Fourth good always. Yes, you have given the right answer. It is BMP, which is called bone morphogenic protein. Bone morphogenic protein. Now let us see bone morpho. See, this is very, very important. Again and again, some sort of question they are asking in this area. Bone graft substitutes is the topic. Bone morphogenic protein is a substance that promotes bone formation and is used in treatment of non-union. When it's going for non-union 3 months later also bone has not united, we can use bone morphogenic protein. It's naturally occurring protein that stimulates differentiation of mesenchymal stem into osteoblast. It helps in initiating bone healing and promoting growth of the bone tissue. PMMA is polymethoxymethyl acrylate. It is a type of bone cement. It is a bone cement. Only with this bone cement we are fixing the prosthesis in total knee replacement, total hip replacement, hemiarthroplasty. So you want to fix a prosthesis to the bone, definitely needs a bone cement that is made up of polymethoxymethyl acrylate. Hey, since this is a revision class, no, the same word you had read in ophthalmology also, polymethoxymethyl acrylate. that comes in hard contact lens. Contact lens is divided into three: hard contact lens, soft contact lens, gas permeable lens. Hard contact lens is made up of polymethoxymethyl acrylate. Soft contact lens is made up of hydroxyethyl methyl acrylate, HEMA. And gas permeable lens is silicone, made up of silicone. Okay, best refractory error correction is with hard contact lens. Good refractory error correction is with soft contact lens. Okay, but hard contact lens will not allow oxygen inside, so easily the lens will go for corneal edema. That is why we are using soft contact lens. Optimum refractory error correction, optimum gas permeability. Okay, that's the reason. Hard contact lens nowadays in ophthal, the indication is keratoconus. Keratoconus, hard contact lens is used. Number 2, irregular astigmatism. Only in these two conditions, hard contact lens is used. Okay, this is for extra point, right? Yes, calcium phosphate is not specifically used for bone formation in non-union. Calcium phosphate compound may be used in bone grafting procedure to provide a scaffold for new bone. Okay, calcium sulfate is used as a bone graft substitute or filler in orthopedics. So this is used as a filler. Okay, this is used as a scaffold. These are the MCQs they can ask. Okay, scaffold. Bone PMMA is a bone cement. Okay, synthetic bone graft substitutes materials are available. Example, calcium phosphate ceramics. Okay, bioactive, this was an asked question. Bioactive glass is a synthetic bone graft substitute. Please read this. Demineralized bone matrix is derived from allographic bone after removing the mineral component. It contains various growth factors and protein that can promote bone healing and stimulate new bone formation. See, in Madras Medical College, they have what is called a bone bank. In bone bank, they are preparing this demineralized bone matrix. This can be used to promote non-union, healing in non-union. Yes. Now, 27-year-old man complains of tightness of chest in the past 3 months. He also complains of pain, low backache and plantar aspect of the foot. Probable diagnosis. Directly it is giving male patient, low backache associated with plantar fasciitis. Diagnosis is good. All of you are very good, very good. All of you have answered. Ankylosing spondylitis. Ankylosing spondylitis. Good. Okay, ankylosing spondylitis. Yes, the real question they are asked in INI-CET. A 40-year-old man is suffering from increasing difficulty in bending forward, stiffness of the spine and reduced chest expansion. A CT was performed, shown below. What is the thing? The CT is showing you some finding. And what is this thing? This is ankylosing spondylitis. See, I am able to see here white color thing. That is calcification or ossification of the anterior spinal ligament. Okay, yes. So it is ankylosing spondylitis. See, ankylosing spondylitis, quickly just we will go about the radiological features alone. Radiological features, this is a normal sacroiliac joint. I am able to see a definitive gap between the sacrum and the ilium. This is normal. Here when you see, you can't say where is the sacrum, where is everything smudged together. So this is called obliteration of the sacroiliac joint. This is the main finding in ankylosing spondylitis. Then one should not forget the edges, the corners of the, here also in CT scan, you see here, the edges of the, I will mark and then I will rub. You just see these 3 red color markings where I made, you just see the corners are shiny, corners are sclerosed, shiny. This is called shiny corner sign, otherwise called Romanov's sign. Otherwise called Romanov's sign. Where you read the same word, Romanov's sign, in micro. Come on. Come on. If we finish this by 8 o'clock, all of us, we can go and we go for our dinner. Okay? Yes. Come on. Yes. Superb. Oh, Sunil, Manish, Billa, all of excellent, man. All of you have answered. That we have read in Trypanosoma cruzi, otherwise called Chagas disease. Okay, in the eye. Okay, so Chagas disease, there's a sign that's called Romanov's sign. Excellent, man, superb. And the paravertebral area, everything will go for. This is called bamboo spine, and this is the spinal ligament. No, Anterspinal ligament is ossified, looks like a dagger, other is called dagger sign. This is dagger sign. And this is okay. We will go to last but one question. This is one question. Next is the last question. This is no real question. Real question of INI-CET. A 7-year-old boy presents to the emergency department after falling on an outstretched hand. X-ray shows an extension type of supracondylar fracture. On examination is unable to make a OK sign. This is called OK sign, making a perfect O, and this is called an OK sign. Is not able to make. So which structure is most likely injured? Very good. Marvelous. All of you are given the right answer. The answer is median nerve. Right. A child has a supracondylar fracture of the humerus. The most common type in children is extension type. Median nerve, especially the anterior interosseous branch, runs anterior to the distal humerus and it is involved in the extension type. The inability to make a OK sign, cannot flex the thumb and make a perfect O, classical sign of anterior interosseous nerve injury, a pure motor branch of median nerve. Okay, marvelous. In flexion type is very rare. 2% is the chance of flexion type of supracondylar. If they specifically ask what is the nerve that is damaged in flexion type, the answer is ulnar nerve. Answer is ulnar nerve. That is flexion type, very rare, only 2% chance. 98% it is only 98% it is only extension type. Okay, right. We'll go to the last question. A 60-year-old woman presents with generalized bone pain and easy fatigability. This is the latest INI-CET question. X-ray shows diffuse osteoporosis. There is hypercalcemia. Which of the following investigation is most appropriate to confirm the diagnosis? Yes. Yes. Very good. Yes. Many of you have. Yes. Pepsi have answered it. Yes. Very good. Very good. Okay. Tamil Moran has answered. Yes. It is. See, a 60-year-old woman presents with generalized bone pain, easy fatigability, may show diffuse osteoporosis. There is hypercalcemia. So it's a parathyroid pathology. Parathyroid pathology. So the best scan for that is system-AB scan. System-AB scan. You see, the patient presents generalized bone pain, diffuse osteoporosis. Hypercalcemia strongly suggests primary hyperparathyroidism. Primary hyperparathyroidism is most commonly caused by parathyroid adenoma. To confirm and localize the overactive parathyroid tissue, the investigation of choice is a technetium 99 system-AB scan. This is the investigation of choice. Okay. CT scan may show calcification or incidental mass but lacks sensitivity. Triple phase, this is very important. This time they may ask this question. Triple phase bone scan is used to evaluate osteomyelitis or bone infarction, not parathyroid. Bone infarction means one particular part of bone is infarcted because of lack of blood supply. So bone infarction and osteomyelitis, the scan that is used called triple phase scan. Okay, so to some extent we have completed in these 2.5 hours. I think this will be useful for you, right? In public YouTube, still my LRR of that last November INI-CET is there. In that I had covered 20 important topics in that. That YouTube is for 2 hours, this is for 2.5 hours. You please combine that also. Definitely it will be more than enough for the last minute revision. It will be very interesting and I hope this session was useful to you. Dear friends, all of you are prepared really very well. I can assess this from your participation. I pray to God sincerely. God is there with us. Almighty is there with us. Definitely this time all of us, we will rock. All the best, dear friends. Thank you so much.